distinguished guests, delegates and colleagues, a very good morning to one and all. With great delight, I, Dr. Kapil Sejpal, welcome you all on behalf of society on this wonderful Sunday morning. At the outset, we would like to extend heartfelt welcome to all our eminent guests on this occasion. Let us begin as we all look forward to have a great academic meeting and to hear from all our esteemed speakers. I would like to request you all to please kindly take your seats. Let us begin with welcoming our faculties. I request Dr. V.L. Gupta sir to welcome Dr. Deshpande sir with a floral bouquet. I request Dr. Acharya sir to welcome Dr. Ajay Kher sir. Now I request Dr. Ukhalkar sir to welcome Dr. Vinita Goyal ma'am. Next, I request Dr. Monali Sahu ma'am to welcome Dr. Girish Kumtekar sir. I request Dr. Pranav Kumar Jha sir to welcome Dr. Afzal Sheikh. I request Dr. Vishal Ramteke sir to welcome Dr. Suyashri Pandey ma'am. We shall proceed now with lighting of Samai and Saraswati Vandana. Let us begin this ceremony by seeking blessings of Ma Saraswati. I request all the guest speakers, Dr. Deshpande sir, Dr. Ajay Kher sir, Dr. Vinita Goyal ma'am, Dr. Girish Kumtekar sir, to kindly join to light the traditional Samai and seek blessings of Ma Saraswati. I also request Dr. Monali ma'am and Dr. Pranav Jha sir to accompany them. Thank you all. I would like to call upon the President of TNS, Honorable Dr. Monali Sahu ma'am, to address the gathering with a welcome note.
A very good morning. Today's dignitaries, respected seniors and dear colleagues. I'm really happy today to have this CME and workshop on CRRT with a lot of interest from all physicians, internists and the nephrologists of course. CRRT started since year 1977 in Germany as CAVH, and with lot of technological advancements, it has progressed to today's fourth generation CRRT machine. We have so many other sorbent therapies, and then from Renal Limited it has become most the multi-organ support therapy, and there is cloud connectivity, which includes not only the monitoring but also we can control the systems. So there is a lot to learn. And where do we stand today in India about these therapies? We are going to learn from today's excellent speakers. We will start with Dr. Ajay Kher, who has got mastery in lots of topics, including acid-base to the whole spectrum till renal transplantation. And we are happy he will be speaking on CRRT modalities. Then it will be followed by Dr. Girish Kumtekar sir, who is the pioneer person in starting RCA in Hyderabad care. So best person to speak on anticoagulation. Then we have Madam Vinita Goyal, Madam. She was instrumental in CRRT therapies, ECMO therapies, the Perspectives conference, and she will be speaking about related therapies to CRRT. And then we have Rishi Deshpande sir, who has worked a lot on intensive care nephrologist, and he will be speaking on sepsis and related therapies in CRRT. So I extend a warm welcome to each and everyone over here today, and thank you. Now, before we proceed to the scientific session, there is something that has been achieved by our own nephrologist, that is Dr. Manish Balwani, and yeah, I thought Manish is not here. So recently we had a Indian Society of Organ Transplantation elections, and Manish was elected on the coveted post of Secretary for Indian Society of Organ Transplantation. And we are extremely happy about that. We are proud of you, Manish, and we would like to felicitate you at the hands of VL Gupta sir. Gupta sir, please come and felicitate Dr. Manish Balwani. I would request Pranam also to Pranav Jha to join. Today we have one more occasion. We have birthday of our beloved senior most Acharya sir, and I would request Dr. Gupta sir to please hand over a bouquet to Acharya sir and wish him all the best, a great year ahead, Acharya sir.
Thank you, ma'am. Now we would be commencing the academic sessions. We will start with the first lecture of today's meet, which is on the topic CRRT, choosing the modality, dose and prescription. It will be delivered by Dr. Ajay Kher sir. To chair this session, I invite Dr. Ukhoykar sir and Dr. Amol Bhawane sir. Dr. Ukhoykar sir is a senior nephrologist and transplant physician at Ashwini Kidney Center, Nagpur. Dr. Amol Bhawane sir is a faculty in the Department of Nephrology at AIIMS, Nagpur. Now I hand over the session to the chairpersons.
Yeah, good morning everybody. Dr. Ajay Kher is a renowned nephrologist from Delhi, and all of us have seen him over the last few years contributing spectacularly to various aspects of nephrology. His qualifications are on the screen for you to see, but I will request Dr. Ajay here to start his presentation to save time. Thank you.
Thank you for the invitation, and thank you, sir, for the introduction. I'll start my talk, which is about choosing the modality, dose, and prescription of CRRT. So before we get into CRRT itself, we should be aware of the alphabet soup of CRRT. So just so that everyone's on the same page. So the first is CUF, which is slow continuous ultrafiltration, in which you have blood. Let me get my pointer as well. So, yes, okay. So we have blood coming in, going through the dialysis filter, and then you have the blood returning on the venous return, and the ultrafiltration is coming out through the dialysate port. And in this, there is no solute clearance, and this is used for removing volume or fluid from a person. And so that is CUF. The next one is CVVH, or continuous veno-veno hemofiltration, in which again blood is coming in and returning through the venous line. You have replacement, which can be either pre-dialysis filter or post, and then you have the effluent, which will include the volume that you've given as replacement, plus any additional ultrafiltration that you're doing, and that will come out into the effluent bag. And so you have solute clearance, which will be from convection, and you have ultrafiltration as needed as well. And so this is CVVH. Then you have CVVHD, which is continuous veno-venous hemodialysis, in which again you have blood coming in and return, and then you have the dialysate fluid going in through the dialysis port, and then the effluent coming out. And again, this has solute clearance, but this is by diffusion, and like any hemodialysis kind of modality, except that it is much slower because your dialysate flows are much slower compared to a hemodialysis situation. And then you have the combination, which is CVVHDF, in which continuous veno-venous hemodiafiltration, in which you are combining both the modalities. You have blood coming in with the return, you have the replacement fluid, you can do either pre or post or combination, and then you have the dialysate going in and effluent coming out as well. So the brief that I have for today are the components of the CRRT prescription. So first you have to decide which mode you're going to use: CVVH, CVVHD, CVVHDF, what blood flow you want to use, the dose, which is the dialysate or replacement rate, whether you're going to do it pre-filter, post-filter, what choice of replacement fluid are you going to do, what ultrafiltration rate are you going to do, whether you're going to do anticoagulation, and if so, which one, and then what additional medicines or treatments do you need to do, especially with regards to potassium, phosphorus, calcium. And so those are the aspects that we'll talk about. And most importantly, which many times gets forgotten, please always ensure that you reassess your antibiotic dosing and other medicines, because once you started this CVVH, you are now going to clear not just toxins and urea, but also the medicines and drugs that you're giving as well. And no one else will recalculate it. No one else will redose. Whatever is on pilot will continue on autopilot. It's only the nephrologist who is taking the ownership of writing the order will also need to take the ownership of reassessing the antibiotic and their dosing as well. So now we're going to go through cases. And before I do that, I do want to get a sense of the room. How many currently have a CVVH or a CRRT machine in their building or are using? So raise of hands. Okay. Okay, so we have quite a few who are actually using it and not here just for theory. So we have a 30-year-old male who presents with nausea, vomiting, altered mental status. has a pH of 6.8 with high anion gap metabolic acidosis. And this is the third case coming into your building post a local made alcohol binge that is going around. So what modality of dialysis would you choose for him? Hemodialysis for 4 hours, hemodialysis for an extended duration, SLED for 6 hours, or CVVH-DEF with 2 liters, 1 liter dialysate and 1 liter post replacement. So show of hands for A. Okay. Show of hands for B. Okay. Show of hands for C. Okay. And show of hands for D. Okay. So we'll talk about the answers. Hemodialysis extended duration. Even though this is a CRRT thing, we're going to talk about how and why we choose different modalities. So HD versus SLED versus CRRT. So when you have toxin clearance or severe hyperkalemia, you want as fast, as much clearance as you can. So the case is a methanol poisoning. So in this case, you want to remove as much methanol as possible, and you will get higher clearance per minute with HD. So if you run a blood flow of 200, dialysis flows of 500, your clearance is going to be somewhere between 220 to 250 ml per minute with an HD, depending on what filter you're using. If you get your blood flows up to 400, you can even get up to 300 ml per minute clearance. This is not something that you're going to be able to get with CVVH at all. So if you want to clear toxins, you want to remove potassium in the fastest way possible, HD is the way to go. Even if you need NORAD or pressors to push and get the dialysis done, for these kind of patients, HD is still probably better. So now if we look at SLED, where is SLED better? So for patients who have hemodynamic instability or in whom you're expecting instability once you start dialysis, compared to hemo, SLED would be better. The advantage compared to CRRT is you don't need any additional equipment, you don't need any additional machine, and compared to CRRT, cost may be better as well. In comparison, CRRT is better for patients who are more hemodynamically unstable, or if you have the additional equipment and you have the manpower that is trained on it, it is going to be costlier. However, for brain edema, so as you do hemo or you do SLED, as you clear urea, there is going to be cerebral edema that will happen because of that. So especially patients who have brain injuries or bleeds, patients who have hepatic encephalopathy, in these kind of situations, a slower modality with slower clearance may offer better outcomes in these kind of patients. And so in those situations, CRRT may be better as well. Something to remember, I'm not going to go into the multiple studies that have happened, but there are randomized trials as well as meta-analyses that look at mortality in AKI as well as renal recovery or freedom from dialysis with hemo versus CRRT or SLED versus CRRT, and there has been no benefit with CRRT over hemodialysis. Similarly, there has not been any consistent finding of increased renal recovery or freedom from dialysis. So the benefits that we are talking about with CRRT are more in terms of how the blood pressure, the pressors, and how we feel when we manage the patients. For actual hard endpoints, there isn't a significant benefit that we've noted yet. So now I'm going to move to a different scenario, which maybe you haven't seen as much, but it's an interesting thought question for those who haven't seen it. So a CKD5 patient, not on hemo yet, but has a creatinine of 5, has CNS lymphoma, and the ONC team wants to give high-dose methotrexate. His survival depends on getting the high-dose methotrexate and surviving the high-dose methotrexate without cytopenia, without significant cytopenia. So they want to ensure that they can get the methotrexate, and then the methotrexate will come out of the body as if this is normal GFR. They will do level monitoring, but they want you to help them because the creatinine is 5. So what modality would you choose? Hemodialysis for 4 hours, SLED for 6 hours, CVVH-DF with 2 liters, 1 liter dialysate, 1 liter post replacement, or CVVH-DF with 5 liters, 3 liters dialysate and 2 liters post replacement. So we'll again take a vote of hands. So A, so hemodialysis, okay, SLED for 6 hours, CVVH-D with 2 liters, Okay, and CVVHDF with 5 liters. Okay, so we have significant with 5 liters. Yes, so the answer is CVVHDF with 5 liters. So the question is that you need a reliable, consistent clearance, not just for minute-to-minute clearance, which is what we were talking about with toxin clearance, but you want consistent for many days, because the methotrexate's not going to get cleared within a 4-hour dialysis session. So one, you need consistent clearance. Two, you want it to be close to the normal renal clearance that you would get with normal GFR. With HD, you get 200 to 250 ml per minute with a blood flow of 300 and dialysis of 500, which we talked about. So the question is, how do you assess CVVH and CVVHDF clearance? And what are the differences with pre and post dilution when you do it for urea or other molecules? And so that's what we're going to go into. So the way you assess clearance is by looking at the effluent rate. So the effluent rate you can look at as ml per minute or ml per kg per hour. And so we're going to look at these three in specific and based on the modality. So if you look at CVVHD, so you have blood coming in, and so let's take a specific example of 200 ml per minute. The hematocrit is 30. So that means you have a plasma flow of 70%, because 30% is hematocrit, 70% is plasma. And so that is a 140 ml per minute plasma flow going into the filter. The blood's going to come out. You have a dialysate flow of, let's say, 30 ml per minute or 1800 per hour. So that's what you've decided that you want to give. And then you have the effluent coming out. So all the dialysate that you've given, 1800 will come out, plus any additional ultrafiltration that you ordered. So in this case, let's say that we've said 180 ml per hour ultrafiltration. So there is the 1800 coming from the dialysate and 180 that we've decided every hour we're going to take off this person. So the total effluent is going to be 1980, and that is about in an hour. So per minute, 1980 by 60, so that is 33 ml per minute. So that is the clearance, and the reason the clearance is exactly that is because the blood flow is 200 and your dialysate flow is only 33. So that will ensure that with this slow flow, there is 100% diffusion, and the efficiency of this system is going to be 100%. So unlike in dialysis, hemodialysis, where you have 300 blood flow and 500 dialysis flow, in these situations, you don't get 100% diffusion or 100% efficiency, which is why you get up to 70% or 65% depending on what blood flow, what dialysis flow, and what dialyzer you have. So in this case, because these are slow flows, you get 100% efficiency, and so the clearance is 100% of the effluent, which is 33 ml per minute. The filtration fraction, which is going to be important when we look at the other modalities of this, so is 3 ml per minute, because that is the additional fluid that is coming out of the blood in this dialyzer, and so that you have to divide by the plasma flow coming in, so which is 140 ml per minute. So 3 by 140 is about 2%. So the filtration fraction in this kind of an order would be about 2%. So now let's look at CVVH with a post-replacement model. So again, blood flow, plasma flow, and hematocrit we are keeping the same. That's coming out. And then we have post-replacement. So in post-replacement, again, I'm going to keep the numbers the same. So we're looking at apple to apple, or in Nagpur, orange to orange. So the post-replacement is 30 ml per minute. So again, 1800 ml per hour. And the effluent is going to come before. And we've kept the ultrafiltration at 180 ml per hour as well. So 1980 ml per hour is going to come out with 33 ml per minute as the effluent rate. As this blood goes through, the fluid, the 33 ml per minute is coming out from this blood or this plasma. So as this comes out, hemo concentration is going to happen in the filter. With this will be solvent drag, which is how you get convective clearance as well. And after this concentrated blood reaches here, that's when the post-replacement will kick in and dilute the blood, and the hematocrit will come back to what it was before. So towards the end, this will get hemoconcentrated, and which is why the filtration fraction is going to be important, because otherwise if you concentrate it too much, you will get rouleau formation and clotting of the filter. So looking at clearance, again, because the blood going in is not getting diluted and the blood flows are slow and the dialysis flows are slow, the clearance is 100% of the effluent. So that is 33 ml per minute, which is what we did. However, all of these 33 ml is coming out before any replacement has gone in. So 33 by 140, which is the plasma flow, is what the filtration fraction is, and so that is 23%. The recommended filtration fraction for post-replacement is about 20 to 30%. And this is true for CVVH. It is also true for hemodiafiltration, which you do with your 5008 machines, because even in that, the same philosophy and same principles are being applied. So you don't want your diafiltration to get concentrated and clot the filters as well from the rouleau formation as well. So again, you want it to in the 20 to 30%, and how much you can go is dependent on the pre-hematocrit, because ultimately your hematocrit goes above 0.4, you will get rouleau formation. So if your hematocrit is 20, you can take off more fluid. If your hematocrit is 30 or 35, there is less fluid that you can take out because the hemo concentration will be higher, and you'll get your hematocrit above 0.4, and then they will start to clotting your filters. So now let's look at pre-replacement, which is a different CVVH replacement model. So again, 200 ml per minute, hematocrit of 30, plasma flow of 140. Now the pre-replacement is going in right before the filter. And again, we've kept the numbers the same, 30 ml per minute at 1800 ml per hour. So now let's say that the blood was coming in at a urea of 100. You've mixed 30 ml of dialysate, which has 0 urea. So now the mixed concentration of urea will be 87, 200 by 230. So the efficiency of the dialysis, now urea coming out in the effluent, the 33 ml per minute that is coming out will have a urea of 87 instead of having a urea of 100, because you already diluted the urea going into the dialysis filter. And so your efficiency is now going to be 0.87. This will depend on the blood flow coming in and the replacement flow going in. So if your blood flow is 120 and you do this, the efficiency will be much lower, versus if your blood flow is 250 and your dialysis flow is lower, then the efficiency will be higher. So again, that ratio will depend on what rates you're using as well. The filtration fraction, again, because the blood's already been diluted here, the hemo concentration that should happen here is just getting the hematocrit back to what it was before the blood got diluted. So in this also, the filtration fraction is mostly driven by the ultrafiltration and not by the replacement that you're doing, which is why if you look at the benefits and the downsides of pre and post replacement, so pre-replacement will decrease the risk for clotting because you're diluting the blood before, there is no hemo concentration that is happening, and so you will likely have better filter life and decreasing hemo concentration. But the clearance that you're getting is getting lowered. So your effectiveness of the clearance that you're getting is going to be lower. And if you want to get the same amount of clearance, you need to increase the replacement fluid rate if you want to get the same amount of clearance at the end. With post replacement, you have an increased risk of clotting, you have increased hemo concentration, and you need to make sure that your filtration fraction is less than 20%. But the advantage is that there is no efficiency loss and there is no reduction in the clearance due to dilution. This, all that we talked about, is mostly small molecule clearance. We're talking about urea as the best example, but will apply to all the other small molecules that we're talking about. However, if you look at other molecules and you look at CVVHD, which is dialysis modality, the dialysis filter and its characteristics will dictate the curve. And as you go above 1000, clearance will quickly, 1000 Daltons, quickly taper off. In comparison, if you have CVVH, which is convective solvent drag, you will go up into tens of thousands. And again, the clearance is going to be the same across all of that spectrum. And if you do CVVHDF, it will be a mix of both. And so that will kind of dictate. So it's important when we talk about, and I know there is sepsis talk as well, all the inflammatory mediators and all of those. So if you believe in that philosophy and want to get rid of pro/anti-inflammatory or whatever milieu that there is, CVVH would be the better modality to get rid of those through CRRT. Though again, like we said, mortality and outcomes, hard outcomes have so far not been proven with either modality. So coming back to the question that we talked about, so if you want high clearance, 5 liters, 3 liters dialysis, 2 liter post replacement. So the effluent is going to be 5 liters per hour, which is going to be 83 ml per minute, and which is very close to your normal GFR. And with 100% efficiency, because this is post replacement and 3 liter dialysis, you will need to make sure that your blood flow is at least 250 ml per minute. Otherwise, with 2 liters post replacement also, you're going to be above 20%, which is the math that we had done before. So the next case, which is something that you would have seen day in, day out, a 50-year-old female, septic shock from a combination of urine infection and pneumonia, currently on 3 pressors, intubated, and severe lactic acidosis, and AKI as well, which is why the CRRT is being considered, and has a weight of 80 kgs. So what CRRT prescription would you choose? CVVH-D with a blood flow of 100 and a dialysis flow rate of 1000 ml per hour with no ultrafiltration. CVVH-D with a blood flow of 200, dialysis flow of 2 liters per hour and no ultrafiltration. CVVH with a blood flow of 100, pre-replacement of 1000 ml per hour with no ultrafiltration. And CVVH with a blood flow of 200, post-replacement of 1 liter and no ultrafiltration. So again, we'll have a show of hands. So how many for A? Okay. How many for B? Okay. How many for C? Okay, so quite a few for C. And how many for D? Okay, few for D. So the answer is actually B. And we'll talk about why it is. So the dose of CRRT, so when we talk about the dose, Ronco's study, Dr. Ronco's study in 2000 showed that 20 ml per hour, 20 ml per kg per hour versus 35 and 40. 35 and 40 were better. And so once his study had come out, everyone was shifting to 35 ml per kg per hour. However, subsequently, there were multiple other studies, including by Dr. Bauman, Tolvani, the VA NIH study, as well as the Australia-New Zealand study, which showed that there wasn't any difference between 20 and 48. So once these studies that were trying to replicate the original study failed, so we've now gone back to the 20 ml per kg per hour as our goal of replacement for clearance. And to get 20, you have to order 25. Because the CVVH machine might be down for a while, they may have to go for a CT, they may have to go for X, Y, and Z. So you order 25 ml per kg per hour so that you achieve at least 20 ml, or if you're doing pre-replacement that your efficiency drops, so that also is taken into account, and that allows you to do that as well. So coming back to the patient, so the patient's weight is 80 kgs. At 25 ml per kg per hour, you need a 2000 ml per hour effluent. To get 2000 effluent, you need either a dialysis flow rate of 2000 or a pre or a post replacement of 2000. So all the other options were thousands. There was only one 2000 option, which is why that's the right answer. CVVH-D versus CVVH-DF, there is no right answer. So either one would have been fine, but the 2000 ml per hour is what we were looking for as the dose that you want to deliver to the patient, because this person is 80 kgs. So this is the next question and the last case. So 50-year-old female, the same female, septic shock has now gotten better. From 80 kg, she is now 95 kgs. She is recovered from her septic shock, is now hypertensive, off all pressors, and Dr. Vinita is now wanting to extubate the patient. But she's saying there is 15 kgs, do something. And the AKI is persistent, currently anuric. The antibiotic and feeds that this patient is getting is about 2 liters per day. So what CRRT prescription would you choose? CVVH, so all the options are CVVH-D, all the blood flows are 200, all the dialysis flows are 2000. So the only difference is in the ultrafiltration. So I have not made it complicated at all. No ultrafiltration, ultrafiltration at 100 ml per hour, ultrafiltration at 250 ml per hour, and ultrafiltration at 500 ml per hour. So now I'll take votes again. So no ultrafiltration, anyone? Ultrafiltration at 100 ml per hour, okay. Ultrafiltration at 250 ml per hour, okay, a lot of them. Ultrafiltration at 500 ml per hour, a few of them, okay. So at least 250 is right. I'm okay with 500 also if you think the patient's volume blood pressure monitoring is okay, but at least 250, and the reason being it is important to recognize that the nurses and the technicians do a CRRT balance. They don't do patient balance unless you have specifically trained them to do that, which is what in the West is majority of the cases. The nurses do a patient balance hour by hour like we do transplant replacement fluid. What has come out, adjust and give fluid in. For CRRT nurses, if they're doing all the ins plus the ultrafiltration out, then their net goal is different. But majority of the nurses will not be doing it, or the technicians will not be doing it. So you have to tell them beforehand based on how much negative you want them. So for this patient, let's say you want to make them negative by 4 to 5 liters in a day, can be higher as long as you feel the blood pressure is stable, and people have even done 10, 12 liters negative in a day. So the daily intake is 2 liters, plus you want 4 liter negative, so that's 6 liters per day. At 24 hours, if you want to do it, so that's 250 ml per hour. So that's where 250 is the right answer. But yes, if you want to be aggressive and the patient's blood pressure is tolerating and you can monitor, you can go faster as well and get as much fluid off so you can extubate the next day, or maybe even in the middle of the day. So the other things that we do need to keep in mind when we are talking about CRRT is, as nephrologists and as owners of CRRT, we have to own these electrolytes. So sodium, potassium, calcium, bicarbonate, pH, even with the ventilators taking some responsibility as well, phosphorus, volume status, as well as drug clearance, especially antibiotic clearance, because those are also in our control and our hands. And if we don't pay attention to them and we don't correct them, then the patient's going to be in trouble. And last slide is about antibiotic dosing. Most of the CRRT guidelines about antibiotic dosing are based on a 2 liter clearance. 1 liter dialysate, 1 liter replacement, or 2 liter replacement, or 2 liter dialysate. The clearances are going to be very, very similar in the 30 ml per minute. So 2000 replacement is about 2000 by 60, 30 ml per minute. So the clearances and the dosing is based on 30 ml per minute. If you are doing something different, less or more, you need to adjust based on what you think is going on with that patient. In addition, most of them assume that there is zero renal clearance, that the patient is oligoanuric, and that is why the patient is on CRRT. So if your patient is not falling into that category, you will have to make the adjustment. And so what I do is I take my CRRT clearance, which I know what I've ordered. I take what I think is the renal clearance, and then I look at what the antibiotic dosing would be. For antibiotics, I overdose. I give the dose higher because the person's going to live or die based on the antibiotic that they got and whether the antibiotic is killing the bugs or not. For all other drugs, I underdose because I don't want toxicity. So for antibiotics, I ensure that I give over. For all other medicines, I'll try and give a little under based on what I think is the appropriate dose for the person. So to conclude, so the components of CRRT prescription are the CRRT mode. We've gone through a few different permutations of presentations as well, of where you would choose CVVH, CVVHD, and CVVHDF. Blood flows are important, the dose based on the dialysate, the replacement, and the efficiency. Pre and post filter we talked about. The choice of replacement fluid in India for many years was limited to one K0 B32. Now there are multiple choices, and again, so based on the patient presentation as well as the patient situation at the time, you may start with one. As they stabilize, you can switch to the other. The ultrafiltration rate will have to be assessed and reassessed on an ongoing basis, and you have to assess not only the machine but also the patient as a whole to dictate what ultrafiltration rate. We have a whole talk about anticoagulation, so I'm not going to talk about that. And then additional medicines that you will need to look at, especially with the K0, is potassium drips, phosphorus. For anyone who's on CVVH for more than 24-48 hours, phosphorus is likely to go down. So either enteral or IV phosphorus will be required. And if you're on citrate for anticoagulation, you will need a calcium drip as well. And like we talked about, antibiotic and drug clearance. To summarize, between CRRT, SLED, and HD, each has benefits. So there are certain situations in which one is better than the other, but majority of situations, they're all equal. It depends on your comfort level, the availability of the technique, and how you want to use the methodology or technique to its maximum benefit. There is no mortality or renal recovery benefit between CRRT and HD that has been proven so far. And for CRRT, consider CVVHD or CVVHDF with post replacement if you want 100% efficiency and minimize the cost of the effluent of the dialysate or replacement fluid that you're doing. You can consider faster replacement or higher dialysate flows for more clearance or more delivery of bicarb for specific patients. But if you do that, make sure you look at your drug dosing, especially antibiotics, as well as potassium phosphorus replacements, because those are going to be higher as well. Decide and closely monitor your UF targets and consider the full patient, not just the machine. Thank you, and I'll be happy to take questions.
Thank you, sir. Thank you very much for such a detailed and informative lectures. And you are rightly said we should consider a patient, not just the machines. Thank you very much, sir.
Dr. Ajay, compliments on such a wonderful presentation like usual. Regarding your case number 1, I wanted to raise the concern about predicting hemodynamic instability in an ICU patient and tailoring our replacement therapies based on the prediction. Your patient was severely acidotic, pH was 6.8. What in your experience are the predictors of hemodynamic instability rather than a state of hemodynamic instability? So we preemptively take our actions based on that.
Sure. So I think there are going to be a few things. First is, what is the goal? Are we wanting to get rid of fluid and getting, so someone has heart failure and we think that the reason for their hemodynamic instability is a poor pump, we may need to take volume off. And if you're planning to take volume off, then that is going to possibly worsen hemodynamic instability as well. So one would be, what is the target and what is the goal, whether we are going to do that. Second is, what is the clearance that we're trying to do and how much or how fast is the clearance. So if you have an AKI patient like this, in which this is methanol or ethylene glycol toxicity, the urea is not going to be high. So there isn't going to be a urea clearance that is going to happen, which also precipitates water shift that causes more hypotension. Third would be additional issues would be related to the pH and the acidotic nature of the patient and the sick nature of the patient. So those would be issues that would be there for someone like this. For patients who are different, so like the other patient that we talked about, which is the common patient, septic shock. In those patients, what they go in with is likely to dictate where they are and how quickly their septic shock recovers, their lactic acidosis recovers, their hemodynamics improve from your antibiotics or treatment of the underlying condition. That is likely to drive the outcome of hemodynamic instability even more than my modality and my choice of modality. All of us have tricks of how we do it for HD or SLED. Increase your calcium, cut down your blood, cut down your temperature to try and get through a dialysis that you're going to do, or HD or a SLED, or ramp up your pressors to get through the dialysis that you want. But ultimately, the modality is probably a less of the contributor to the hemodynamic instability. It is more the milieu of the patient and the course that they're already on. And if their septic shock and the underlying condition has gotten better, then the instability is likely to be better.
In SLED, how much does blood flow contribute to hemodynamic instability, and is it really essential to bring down it to 300 ml, or anything higher would also do?
So I think the blood flow and its contribution to hemodynamic instability, whether in hemo, whether in SLED, or whether in any of these situations, is predominantly based on your urea clearance. The urea is coming out of the blood, the urea remains inside the cell, and water goes into the cell to cause intravascular volume depletion. That is the main mechanistic explanation for why your blood flow being high or your SLED/CVH being hemodynamically more stable. That is true for people who have high ureas. If you have a patient who doesn't have a high urea, as you get rid of as you do blood flows for those patients, which is majority of your AKI, they are not ureas of 400 for 6 months. For when we start our hemo patients who have risk for dialysis disequilibrium, and so there you have to really be careful how much urea is coming out, what blood flow you're running. For majority of your AKI patients, the contribution of the blood flow and urea removal into hemodynamic instability is going to be very, very small. Unless they've accumulated urea and they're like AKI on CKD rather than AKI by itself. So that's likely less. Your ultrafiltration rate and the other parameters are likely to be higher drivers.
Excellent. Thank you.
Yes, sir.
Please go.
This is just a comment. You asked about the hemodynamic instability and relation of blood flow. So the relation of hemodynamic instability has nothing to do with the blood flow. It is the capillary refill rate which determines the hemodynamic instability. So for example, you are sucking out say 1.5 ml per kg per hour of fluid in 1 hour, and the capillary refill rate with which the interstitium water is getting into the vascular compartment, it has 0.9 ml per kg per hour, the patient is going to get hypovolemic. If the capillary refill rate is matching the rate of ultrafiltration, then probably you can achieve higher ultrafiltration without hemodynamic instability. And that is the beauty of CRRT. So the studies have come up with 1.3 is the magic number per kg per hour. The ultrafiltration should not exceed that number. If you are say want patient fluid removal of in a 60 kg guy, so you can go up to 75 ml net negative. If net negative means you are giving IV fluids, injectables, TPN, everything say 1 liter in an hour, you can take out 1075 ml per hour. So the blood flow, the replacement rate, the dialysate flow, they have nothing to do with the hemodynamic instability. It is the matching of the patient fluid removal and the capillary refill rate. That will, that's what I have to say.
Sure.
Thanks. So, fantastic presentation, Ajay. Just a thought. The second case that you had, now you had a
Methotrexate.
patient on CKD stage 5, not yet on dialysis, going for chemo with methotrexate.
Methotrexate.
Now, as we all know, methotrexate is highly albumin bound, and you will need a dialysis which will be for a prolonged duration. How will you balance the risk of getting a dialysis disequilibrium with the enhanced dialysis that you were giving versus trying to go for a lesser amount of dialysis, because actually matching the GFR to remove to ensure methotrexate clearance might not always work, as we know. So how do you balance that?
So again, so this was a specific case that to kind of drive that you can get GFRs very close to near normal GFRs with CVVH. The advantage with CVVH is it's a 24-hour system, so you can continue to give normal GFR for days with CVVH. So the goal was to kind of highlight that. The methotrexate case does bring up the possibility of dialysis disequilibrium. However, with CVVH, because it's a slower flow, continuous, your drop is not going to be sudden. It's going to be a slow drop. Plus the cellular, intracellular urea will continue to keep coming out at a continuous rate as your urea drops in the intravascular compartment. The chances for dialysis disequilibrium will be lower than HD, where in 4 hours you empty the blood out with a full HD session. So that would be something that would be different. So for a methotrexate kind of specific one individual case basis, that's a different story. But yes, if you are going to do hemo on someone who is uremic in someone for clearance, then you will run the risk of dialysis disequilibrium. And so you would have to be very careful how you want to do that for that patient.
Dr. Kandikar.
Yes, ma'am.
Yeah.
So there's no sodium profiling available on
Yes,
CRRTs,
there
and
is.
sometimes we need higher sodiums to,
Absolutely.
So any workaround for that?
So again, the workaround is that the math on this is simple. If you want to sit down and just do the math, you will need to give 3% replacement on a separate line. You can do it separately in a separate center line. You can do it on the return line on the CVH machine as well. So if you have someone who has a sodium of 110 or 120, you can bring it up because the sodium you're running here is 130 to 135 depending on what fluid composition and which company's supply you're looking at. So that will bring it up in a slow, steady manner as your urea is coming down with the CVVH. So the sodium will come up. If you have the reverse issue that now you want to bring it up from 130 to 140, 145, or if you have someone who has a brain bleed and you want to hit to 150 as well, then you will need to give something additionally. And so the additional thing would be 3%. You know this is 524. You know your fluid is running at 2 liters per hour. You do the math, you add it in the post replacement or a separate central line, and you monitor it frequently, and that is kind of how I would do it.
Thank you.
Yes, ma'am.
Yeah, I want to ask, in your case number 5, she became already hypertensive. We want to continue with CRRT. When do we stop? Do we have a step down approach with SLED and of course she had a lot of ultrafiltration to be done. So
Absolutely. So ma'am, perfect question. So again, all of those options are available, and which one you choose is dependent on a personal preference. So the case I made was you could have even switched to SCUF, and a SCUF modality with just removing ultrafiltration and getting rid of ultrafiltration, forgetting about urea clearance because they've been on CVVH for 3 days, 4 days, whatever time they've been on. And you could say, my target is ultrafiltration because I just need to extubate this patient. And then we will reassess for SLED or HD the next day. And so that could be one approach to this patient. You could continue CVVH, the patient's been on CVVH, and we'll just add ultrafiltration to the same modality. You could absolutely switch to a SLED. You could absolutely switch to an HD because the patient has the blood pressure. The problem with HD is going to be you have 2 liter fluid going in that 24 hours. You have 4 liters that you want to get rid of. 6 liters in a 4-hour HD is refill rate, as sir talked about, is going to be a problem. Even on a 6 or an 8-hour SLED, 6 to 8 liters ultrafiltration may get you into hypotension because of refill rates. So CVH or a 24-hour SCUF is likely because your refill rates are going to be good and you might be able to get rid of all of that at a 24-hour much more amount than this. And the reason I put the urgency is because you want to extubate the patient. If there is no urgency, you can do it over 2 weeks. Who cares? But the urgency, which is why I pushed the story there, is so that there is some urgency to get rid of the extra fluid. And the CVVH modalities or continuous modalities do give you that leverage of getting more fluid out, which is one of the advantages that you have in this, because the refill rate, you are getting fluid out at that rate for 24 hours. And so that gives you more advantage.
Excuse me, sir. Sir, one question from live chat. Actually,
Sure.
Dr. Maharajan wanted to ask, CRRT in rhabdomyolysis, myoglobin, any specific filter used?
Any specific filter? So I can't say that I have used any filter for rhabdo or myoglobin, because again, the molecular size that you're looking at is a much bigger molecule. So I don't think I have any knowledge, but I don't know if anyone else has in the audience.
Myoglobin urea and myoglobin induced AKI, the molecular weight of myoglobin is around 17,000 Daltons. Okay, so we can use a medium flux dialyzer or a high flux dialyzer. So the options we have are 4. One is cytosol, we can use that one, adsorbent. Second is plasma exchange, gold standard. Third, what we used was a filter called Theranova, which is a medium flux filter, which costs around 5,000 rupees. We used it in a patient for 4 sessions, and luckily we got it published in IGN also. So we gave a cost-wise comparison also. So we have Thera Lite, we have Thera Nova, we have Plasma Exchange with P2 filter for adult, P1 for pediatric age group, and Cytosol. out of which the Terra Nova was the most cost effective. They all can remove myoglobin, that's not question, but the cost effectiveness is Terra Nova, and that will give you advantage of dialysis also. So we can do a slide on it, at the same time you take out the myoglobin. So I think that answers the question.
Sure. Thank you, sir. Thank you. Thank you very much, sir.
Thank you.
Thank you, sir, for the informative talk. I request the chairpersons to present a memento of appreciation to Dr. Ajay Kher, sir. I request Dr. Khandekar, sir, to present token of appreciation to the chairpersons. Thank you, chairpersons, and thank you, Dr. Khandekar, sir. We now proceed to the next session, which is on the very important topic, anticoagulation in CRRT. To guide us on this topic, we have our next speaker, Dr. Girish Kumtekar, sir. To chair this session, I invite Dr. Shivnarayan Acharya, sir, and Dr. Amit Pasari, sir. Dr. Acharya, sir, is a senior consultant nephrologist and transplant physician at KIMS Kingsway Hospital, Nagpur. Dr. Amit Pasari is a consultant nephrologist and transplant physician at Saraswati Kidney Care Center, Nagpur. Over to the chairpersons.
I welcome Dr. Girish Kumtekar, and he is going to talk on a very important topic of anticoagulation in CRRT. As you know that the CRRT filters as such are very costly filters, and the cost of CRRT will depend upon the life of the filter. So we have to balance very carefully about how much anticoagulation to be given and how to regulate it, because if you give more, then there may be complications like cerebrovascular episode or GIT bleed, etc. So now I request Dr. Girish Kumtekar to go ahead with his talk.
Thank you, sir. Thank you so much. My sincere thanks to the organizers for the invitation. And thanks to Dr. Kher for making my life simpler by covering the most difficult part of CRRT. I'll be talking about anticoagulation for CRRT, and these are my affiliations. None of them has got anything to do with today's talk. So I'll straight go to the options which we have for the anticoagulation CRRT. So to begin with, there is no debate that we want anticoagulation. We need some kind of anticoagulation to keep the circuit flowing, because the circuit needs to flow for n number of hours without fouling the filter, without coating the filter and hampering the convective and diffusive clearances. That is all we want, and the options are not too many. We need systemic anticoagulation, we need regional anticoagulation, and these are the options like unfractionated heparin, low molecular weight heparin, argatopran and bivalirudins, and in regional we have unfractionated heparin with protamine reversal. So the basic concept of regional citrate and the basic concept of unfractionated heparin is the antidote concept. So we push in something which will keep the fluid state of the blood preserved throughout the circuit, and the antidote, which is here calcium and which is here protamine, will reverse the anticoagulation when the blood is going inside the patient. So this is the basic understanding of regional. Systemic is where the entire system, including the in vivo blood and the extra corporeal blood will be anticoagulated. So this is what we are talking about. Heparin, our old friend. I will just touch base on heparin before going on to the renal citrate. So the heparin is usually given conventionally as intermittent boluses, continuous infusions, preceded by intermittent boluses, and the doses are pretty simple with a monitoring of the APTTs. So the APTT is monitored in the pre-filter segment, post-filter segment, and the patient's filter segment, and the doses are pretty simple. We run with a 10 to 20 milli in international units per kilogram per hour, and the boluses are 1.5 to 2.5 times the infusion rate, and the target APTT will be say 1.5 times the baseline APTT. So this is our old friend with which we are quite acquainted. So I'll not go into details. Thus I will want to touch base on where we don't want to give heparin. We don't want to give heparin in all these conditions where there is an extra risk of bleeding. Bleeding in the cranial compartment, bleeding in the splanchnic compartment, bleeding in the thoracic compartment, and what is not mentioned here is the heparin-induced thrombocytopenia. So the thrombocytopenias here could be per se thrombocytopenia because of the underlying disease, or it could be heparin-induced thrombocytopenia. So this is where we don't use heparin molecule. Then came the guidelines, which are quite old, 2012, and we are expecting an update very shortly. And they say that the level of evidence is 1B for use of regional citrate anticoagulation whenever it is not contraindicated. So unless contraindicated, for all modalities of CRRT, regional citrate will be the first choice. That is what the guidelines are saying. And if there is a contraindication to regional citrate, we can think of unfractionated heparin, we think a low molecular heparin rather than no anticoagulation. So we do not talk of intermittent flushes, given saline and keeping the circuit fluid. So giving flushes is last on our priority. So we need anticoagulation. First choice is a regional citrate, second choice is heparin or its analogs. Whenever there is a hit, we go for a molecule which is chemically little different, antigenically little different for heparin, and these are only two, which is argatobran and the fondaparinux. The fondaparinux, the molecular weight is little smaller, so we have to give it on a regular basis, maybe 2.5 to 5 milligrams. But the argatobran, there are whole different protocols which I am not going to detail. In patients with heat, with severe liver failure, it is rather argatobran rather than a fondaparinux. So these guidelines from the KDIGO are pretty simple, but they are very difficult to practice. I will show you how. So this cartoon, how many of you are seeing that systemic heparin is better and systemic heparin is not better? How many of you feel heparin is good for anticoagulation? How many of you feel citrate is good? Okay, so it is just our perspective. It is always decided based on case-to-case basis. Nothing is good, nothing is bad. It depends on the patient, the demands of the CRRT and your goals of the therapy. So CRRT is a goal-directed therapy. We have to set our goals before we start it. And here I start my talk. So the learning objectives are, I will be talking about regional anticoagulation, predominantly citrate, the physiology of how citrate works. I will just go and touch base on the history of regional citrate and actually how we did citrate. Then what are the troubleshootings, and citrate is not without controversy, so I'll just highlight few of them. So let us see what are the basics of regional anticoagulation. So I just highlighted what are the options. So these are the options for regional anticoagulation. There are too many, out of which nafamostat is still being used in Japan. We are not using it here. There are multiple studies on heparin and protamine. Protamine being an antigenically very active, it is not used because of anaphylaxis. In Canada, if you go to places like Ottawa, they have citrate put into their dialysate bags. So they use citrate as a regional anticoagulation by using it into the dialysate bags. So it is a quasi-regional anticoagulation in Canada. What I will be talking about is the regional citrate and calcium. So how we do it? So this I would just like to go through one by one. So this is the circuit where the patient's blood is coming out. Then it is going into the dialyzer and it is going back to the patient. And what we are maneuvering is the entire circuit with multiple bags. The first maneuver is the citrate which is added to the access line. And as you can see, the citrate which is added is by default with the before the pump. So it is pre-blood pump citrate. Okay, so the rate of citrate absorption into the circuit is determined by the pump speed. You increase the pump speed, more citrate gets into the circuit. You decrease the pump speed, less citrate gets into the circuit. So the citrate delivery to the circuit is by default pre-blood pump. So this is first bag. The second bag is a calcium citrate complexes getting into the effluent. So here citrate is delivered. It gets attached to the calcium. It forms a calcium citrate complex. This calcium citrate complex prevents blood from clotting. All right. Out of this, 60% of calcium citrate complexes are drained into the effluent bag. So only 40% calcium citrate is getting to the patient. Okay, this is the second bag. Third is the dialysate. So when we are talking about dialysate, we don't want calcium here. Because if you add calcium here, the whole segment gets clotted out because it's an antidote to the citrate. So we want a dialysate bag which is without calcium. All right. So calcium free dialysate, this is the third intervention, third bag. The fourth bag is the post filter replacement. This can have calcium. Okay, because this is beyond the drop chamber. This is the venous chamber, what we have where there is a blood air level. Okay, there is a blood air level or blood saline level, and the clotting actually starts here. But you can add calcium containing fluid here, which is the post filter replacement. So these are the four bags, and the last fluid, which is the most important, is the antidote. This calcium, this is the syringe pump which goes here, which is the end of the circuit, which is the calcium. So whatever citrate you have infused here is getting neutralized by the calcium. This is the antidote. So by all practical means, the anticoagulation is only extracorporeal, which is the regional anticoagulation. Nothing goes into the patient. So the bleeding risk to the patient is null. Patient do not bleed with citrate. Okay, so this is very clear. So we are giving citrate here, we are giving calcium here. This is regional citrate anticoagulation. All right. So this is the separate IV line. There are multiple software upgradations. Now we are having a separate IV line. We can put it onto the circuit, on the patient. That is a different story. But we have a antidote here. Okay. So by this schema, we understand that the rate of citrate delivery and the rate of calcium infusion should match, so as to keep the patient's calcium in a strictly normal range. That is what we want. If we achieve that, we don't get into complications like hypocalcemia, acidosis, alkalosis. Okay, so this is what happens with this schema. All right, and then we have to see what kind of solutions we have in market. So this is all theory. Do we have it? Do we have an access to it? The answer is yes. So these are the commercial citrate solutions. This is from Baxter. And all these solutions, they have evolved over time. But presently what we are using is this much. It is the Regiocit 18/0. This is isotonic citrate what we are using presently. All right. So this is one option. The second option, what the Fresenius gives us, is a plethora of solutions. This is the same schema. All right. So here the citrate solution is 4% sodium citrate. This is trisodium citrate. Okay. If we go back, this is just a citric acid. There is no citric acid here. There is no trisodium citrate. This is just sodium citrate. All right. So one citrate molecule attached to one sodium molecule, that is sodium citrate. Okay. This is for isotonic citrate solution, which is from the Baxter. And our Fresenius gives us 4% trisodium citrate. So the sodium load in this schema is more, and it is hypertonic. Understood? So more sodium is getting into the circuit. That has to be balanced by a dialysate which is having low sodium. We don't want patient to get hypernatremia. Okay, so the hypertonic trisodium citrate is taken care of by hypotonic dialysate. Understood? I think this is not at all complicated. Okay, and then we have replacement solutions, which is shown here. This got exhausted. Okay, so the replacement is in blue, and that contains isotonic 140 milliequivalents per liter of sodium. Okay, so that is how the schema works, and these are the bags what we have. These are multi-bigs which have different potassium concentrations. You are treating a patient with, say, hypokalemia. You are using 4 millimoles per liter of potassium, 4K bag, which is multi-bigs 4. You are treating hyperkalemia. You don't want potassium in the dialysate. You treat with 0 calcium. Okay, so it is case to case. You are treating hyperkalemia. The potassium goes up to 4. You don't want this. You use a normal potassium, 2 milliequivalents. So these bags are offered by the Fresenius. Thank you. So these are the bags which are hanging here. Okay, and these are the dialysates, which is called as CICA. CI stands for citrate, CA stands for calcium. So these are CICA solutions, and as you can see, because of the hypertonic trisodium citrate, we are having sodium of 133. So we are having a sodium 133. Okay, so the trisodium citrate, which is hypertonic, which is balanced by low sodium dialysate. The name of the dialysate bag is CICA solutions. The CICA solutions are K1, K stands for potassium, K4 stands for 4 potassium, and we have K2 plus. The P stands for phosphorus. Okay, how many are intensivist colleagues here? Critical care? Okay, so the most difficult trouble for a CRRT patient on ventilator is difficult weaning. They don't get out of ventilator, and the phosphorus is the cause of the difficult weaning. Okay, so these solutions, they have high phosphorus because the effluent is draining all the phosphorus from the body. Patient gets hypophosphatemic. The protein intake is compromised, so less phosphorus is generated. So these bags, they are plus bags. P stands for phosphorus. So we have all these permutation combinations. So first we saw these bags, which are isotonic citrate solutions. Then we are seeing hypertonic citrate solutions and the complementary replacement solutions and dialysis solutions. All right, so this is the hardware which we have at our disposal to run our regional citrate program. Okay. And what is the difference? I mean, what is the difference between all these solutions? The difference is very simple. The difference is how many bicarbonate they generate. So I want to correct the acidosis little quickly. I will use this bag, which is a trisodium citrate, which will give me 320 bicarbonates per liter. Okay, so the citrate is a component of Krebs cycle, which gets into the cell without the help of insulin, which is insulin independent. It gets into the mitochondria, attaches into the Krebs cycle, gives us water and bicarbonate. So the correction of acidosis doesn't start extracellular, it starts intracellular. And then the bicarbonate spills outside the cells into the circulation. So the ABG will not move for some time. Okay, so we are under tremendous pressure to increase the bicarbonate. People are sitting in our head to increase the bicarbonate from 16 to the magic figure of 24. That doesn't happen with citrate, because the intracellular acidosis is collected first. Then it will spill onto the circulation. Okay, is that clear? Right. So this is the difference of choosing the bag. I'm just giving you multiple options on how to choose a bag based on case-to-case basis. There is no blanket prescription for CRRT. Okay, it's a need-based solution. Okay. So now this is what the first time I'm doing this. I'm just comparing two different company products. Okay, I have no bias towards anybody as long as it serves my purpose. So we have isotonic citrate solutions, we have hypertonic citrate solutions. Both are good. Only thing we need to know how to use them. Okay. So going further, this is the history, how the regional citrate started. It started with Dr. Mehta from San Diego. He started with a trisodium citrate. And as you can see, the citrate was 140 sodium and 4 times it 480 sodium. The flow rates were very low, 140 to 220 ml per hour. Okay, the sodium, the replacement was isotonic, 0.9%. And the dialysate was having sodium of only 117 to balance the 408 sodium in the anticoagulation. Okay, so this is how it started. And now, Tobe and now to Tolvani, the Tolvani solution is almost sodium of 140 in the citrate solution, what we use at Regiocit. And the dialysate has a sodium of 140. So both are isotonic. We are not bothered about sodium. There won't be any hypernatremia. There won't be any reflux hypertensions. Okay, so this is how the citrate has evolved from 1989 to 2006. And these are the evolution of the citrate solution. This is regional citrate anticoagulation. Okay, and the physiology is very simple. Citrate binds to calcium. Calcium is important for every step of the coagulation cascade. Every step of coagulation cascade is neutralized. There is no clotting. Everybody is happy. Okay, but we have to maintain this magic range. So this is 0.8 to 1.6. Okay, and the systemic will be 1.1 to 1.3. So we are giving citrate into the circuit. The circuit should have an ionized calcium of 0.25 to 0.35, very low, to keep the blood thin. But once it goes into the patient's blood, the patient's ionized calcium should be around 1.1. The range is 0.9 to 1.1. Few of your ABG machines, they are giving calcium in milligrams. They don't give in millimoles. You have to request your biochemistry colleagues to give it in millimoles. If they don't cooperate with you, it's okay, no problem. Multiplied by 0.25, you have a correction factor. It comes into millimoles. The target is post-filter ionized calcium of 0.25 to 0.35. Systemic ionized calcium of 0.9 to 1.1. If you achieve this, citrate program works very well. So these are just the normal ranges from multiple studies, and this is the chelating ability of the citrate, what we see. And what is the fate of the citrate calcium complexes? What we saw is that 60% of it lost in the dialyzer. So you are not bothered about citrate getting into the blood and causing citrate toxicity. You have to neutralize the citrate for only 40% of what you have infused in the patient. That is quite an easy job. Okay, so the last point I am highlighting is that the half-life is just 5 minutes. So the window of opportunity is only 5 minutes. In other words, the threat is also of only 5 minutes, because body is going to neutralize the citrate immediately once it gets in contact with the mitochondria. It's just the body's metabolism, how we are dealing with it. And that is the reason when the lactates are high, beyond 6, when the anaerobic metabolism has taken over, the citrate consumption goes down. So for most of the operators, it is not the liver dysfunction that prevents them from using citrate. It is the lactate levels that prevents them from using citrate. So our lactate level is 6. So we will not use citrate if the lactates are going up beyond 6. Few centers use 8. Dr. Manish from Singapore, he uses 4. So he has very low threshold for not using citrate. We have little higher threshold for using citrate. So that is an individual variations. Okay, so this is just a fate of the citrate complexes. And it was already a traditional teaching to all of us that it is the liver that metabolizes citrate. Not true. Every tissue in the body metabolizes citrate, including the muscles, including the fat cells. Everywhere where we have a mitochondria, citrate is metabolized. So don't be bothered that there is liver dysfunction, bilirubin of 4, and I can't use citrate. That doesn't case. But look at the lactate levels. And how people did regional citrate anticoagulation is very interesting to see. So this is the schema where we have, this is the Fresenius machine. This is a very beautiful machine. This is the multi-filtered Pro. The Pro stands for some carbon dioxide advantages. And here we have all these solutions which I have just told you, the filter name is ultraflux. The Sika dialysate is low sodium dialysate, what we saw. The calcium is calcium chloride, which is Calracia, and the sodium citrate, which is 4% trisodium citrate. So this is the hardware and this is the machine. And this is for the Baxter. This is the Prismaflex, this is Prismax. This is just a picture, which is not hitting the market. And these are the solutions. These are the pre-filled 5-liter bags. And this bifossil, bi stands for bicarbonate, pho stands for phosphorus, and sil is synergy. So the bifossil is their dialysate bag, which can be used as a replacement bag also. So their bag will have phosphorus inbuilt. And so this is how we just play with the solutions, targeting the patient's needs. We have to, so phosphorus has come down to 1.6. I have to use the phosphate containing bag. Or I end up giving phosphorus intravenously from a separate line. That I don't want to do, because that volume is not removed by the machine. I have to put it as an ultrafiltration. Okay. And these are just a few protocols. This is San Diego, Dr. Mehta. This was published in 1989. And this is almost multiple fluids around to play with. So there are multiple permutations and combinations to generate a blood picture most favorable for patient's recovery. So we want a blood picture, say bicarb of 18, sodium of 135, potassium of 4. That blood picture we want to generate based on all these bags. Then came this is from Tobey. One bag was removed because his dialysate sodium because he is using the ADS citrate, which has a sodium of sodium of 74. So the one bag came down. Then came the isotonic citrate. Now we have only 3 bags. So the number of bags around the CRRT machine have gone down as the renal citrate anticoagulation has evolved. And this is what we exploited for, this is 2018 publication. So this we saw in almost 13 to 18 patients. We did renal citrate anticoagulation exclusively, and we found nobody having clotting, nobody having bleeding tendencies, nobody having alkalosis, nothing. As long as we keep our targets in that narrow range. So we could not have all the side effects. Then we looked at, can renal citrate be used only in CRRT or can it be combined with ECMO? We could do that. So it's in hybrid state also. And when we combine it with ECMO, the requirement of heparin, which is very huge in ECMOs, the tubes are very thick. We have to use a lot of heparin. The requirement of heparin came down. The incidence of thrombocytopenia came down and the patient recovery was good. So this was our contribution. Here we use ADA. And then we started digging little deeper into citrate because we got little interested how it is working so nicely. Then we understood that if a patient has a 0 citrate metabolism, patient is having fulminant hepatitis, we presume citrate is not metabolized. Can we use citrate in these patients? So answer came yes. We had multiple these reviews where we found that we can use citrate with a fulminant hepatitis also, provided the lactates are in range. This is how this was started working. And the surrogates of citrate accumulation, I'll tell you just shortly, that has to be in the range. Then is citrate only an anticoagulation? Is it beyond anticoagulation? The answer is yes. It is a source of calories. So one bag of isotonic citrate, 5-liter bag, gives us almost 520 kilocalories. These are insulin independent kilocalories. And those who are working in critical care, they know these patients are insulin resistance. That is acquired resistance to insulin because of sepsis and vasopressors and all those kind of things. Citrate gets into the cell without insulin, gets into mitochondria without insulin and generates calories for us. So that is a source of calories. The patient may thrive on it when the insulin is not working. So this was 512 kilocalories per day. That is what the citrate bag is giving us. So the trends have changed over time. The number of bags have come down from 5 to 4, 4 to 3. Around the CRRT machine, the dialyzer sodium has gone up. Now it is matching our plasma sodium around 140. The lactate concentration has come down. So at the cost of low flow rates, high concentration, now you have high flow rates and low concentration. The concentration was 400 to begin with in 1989. Now it is 140. We are happy with it. The citrate concentration, it was 140. It has come down to 18/0. And there is no citric acid to it. So citric acid leads to carbon dioxide generation. It will cause some hypercapnia. We can get into some type 2 respiratory cirrhosis, which is not there now. It is only sodium citrate, 140 to 18. And the citrate flow rates have gone, so we have to deliver that much of citrate with low concentration. The flow rate has to go up. So it has gone up from 140 to 1500 ml per hour. So this is how the citrate evolved, and what is the result of it? The circuit life has increased. So now we have 86% of dialyzers or the circuits surviving beyond 24 hours, which was only 50%. So the circuit life has increased significantly. And see, this is always a talk of town, citrate versus heparin. My personal bias is that it has to be case-to-case basis. But the literature is now very much supportive of using a regional citrate, because the graph shows that from hours of start of therapy, it has going down, the mortality is going down, the mortality is all good with regional citrate. So the bias is always toward regional anticoagulation, but my personal thing will be it is case-to-case basis. How we did regional citrate. So what we do, we first try to understand the patient's need. All right. The KDIGO says 25 to 35 is the effluent dose. Sometimes we don't follow it. We look at the patient's needs. If the patient has a pH of 7.1, bicars of 10, and very much in a critical state, we go up to 40, we go up to 50. That is not a taboo, as long as we are getting our targets. Okay. So what we do, we find out what is the QB's blood flow rate. 60 is the patient's weight. D citrate is the dose of citrate. R is the citrate, the rate of the citrate infusion. And how we do it? 150 is the blood flow QB. 60 is patient's body weight. 3 millimoles per liter is, I'm talking about isotonic now, it's the radiocit. 3 millimoles per liter is the rate of citrate delivery. So you enter 3 into the machine calculates it and gives you a rate of 1033 ml per hour. So for citrate anticoagulation, you don't enter the rate, you enter the concentration. The machine calculates the rate, okay? And 18 is the concentration of citrate into the bag. We had radiocit of 18/0. So that gives me 1500 ml per hour. So this is how I calculate the replacement, the rate, the QR I calculated. And you can see if I am changing the blood flow, the rate of replacement changes. So while doing regional citrate, do not change the blood flow unless you want to change the citrate delivery. Because citrate delivery depends on the blood flow. You keep the citrate amount same, which is 3.0, and if you are just changing the blood flow rate from 1500 to 100, the rate is changing. Okay, so we have to be careful about the blood flow rate. And this is the treatment flow chart. This is how we keep going. There is the calcium-free dialyzer. This is the effluent post-filter replacement, which is containing the phosphorus. There is a citrate anticoagulation, and this is how the flow chart goes. And there is an antidote of calcium with a target ionized calcium of around 1, 0.9 to 1.1. This is the standard deviation. And this is the Prismaflex platform, which is now giving you the calcium syringe placed at the place where we used to keep our heparin syringe. Okay, so the calcium is not outside the circuit now. It is incorporated into the machine. You keep the syringe into the machine and ask the machine to give us compensation. So you want to compensate for the calcium loss to 30%, 40% or 200%. Patient's calcium has gone down, You ask for 200%. Patient's calcium has gone up, you get less compensation. The things are very simple now. Okay. And this was the Kalmar protocol which came up for the weight of the patient based on the blood flow, the dialysate flow. This is yet to be published, and how we get the results into the dialysate flow. The replacement fluid rate keeps changing, and as per the patient's weight keeps changing. It is a weight-based therapy with a fixed compensation of 100%. And this is how we troubleshoot if we get high post-filter. PF is post-filter calcium, and this is the patient's calcium. So the middle white is what we want. So middle white is normal ionized calcium, plasma calcium, and normal post-filter calcium. Normal means within the range. And this is what we do with the multifiltrate pro. This is the Fresenius machine. This is the starting settings. This is the setting with which start the therapy. Then we keep monitoring the patient and change our flow rates. So we have a blood flow rate of 8. These are 3 combinations where we can see that the citrate dose is same to begin with, which is 5 millimoles per liter. Earlier we started with 3, now it is 5. The dialysate flow changes, the calcium dose remains almost the same because it is the same to neutralize the citrate. Okay, and this is the beginning of therapy. The flows will change as per the need and the patient's lab values. And we started, and what we do, we first try to understand what is the patient's need, and we try to understand the effluent dose. So we say 40 ml per kilogram per hour, we multiply it by weight, and then we divide it into 2 streams, 50% dialysate, 50% replacement. And till the patient is off vasopressors, we do not do any patient fluid removal. Our orders are to keep in even balance. So whatever the nurse is giving, we ask the technician, so take it out. Nothing above that. So the orders are keep in balance. So the infusion rate for say some saline, some antibiotics are say 60 ml per hour. The patient fluid removal will be 60 ml per hour. Then when the patient's hemodynamics stabilize, I ask the technician to do say 20 ml net negative. So how he does that? The nurse is giving 80 ml per hour into the patient. The technicians take out 100 ml per hour. So this 10 ml net negative. So I am making net negative. But whatever is being given, that I take out mandatorily. Sometimes I have to make it positive also. So I give something. So this is how the working goes on. And this is how the normal ranges which I just told you. These are just what we do. We check sieving coefficient and citrate accumulation index on a daily basis. The sieving coefficient is checked by checking urea of the patient. At the same time, we check urea in the effluent bag and we divide it. The ratio has to be 0.7. If it goes down, there is starting of the filter fouling. The filter is getting coated by plasma proteins or something like that, and the diffusion is not happening. So even though the circuit is working, we recommend to change it. We actually change it. And the citrate accumulation index, see, we don't have any labs that gives us citrate blood levels. So we rely on citrate accumulation index. So we check the total calcium, which is a milligram per dl. We check systemic ionized calcium milligram per dl. We divide it and multiply it by 0.25, which is the correction factor, which should be less than 2.5 for patients with normal liver function. If patients have liver dysfunction, it has to be less than 0.1. This is the surrogate of citrate accumulation. If the citrate accumulation index goes beyond 2.5, it indicates citrate toxicity. Stop the therapy or bring down the citrate infusion or bring up the dialysate flow. Something you have to do to remove the citrate from the patient. And I'll just show you this. These are the useful formulae when you are running a citrate program. Effluent bag urea divided by blood urea gives you a sieving coefficient. Multiply it by the effluent dose, which is 30 ml per kg per hour, 40 ml per kg. It gives a urea clearance. It is just like URR what we are doing in our hemodialysis. So we are getting not only the diffusive clearance, we are multiplying it by convective clearance. So that is a more authentic way of saying that whatever I am prescribing is being delivered. So what I prescribe, sometimes a dose of say 30 ml per kilogram, the delivered dose is just 28. So I have to see the delivered dose is optimum. This is done by getting these urea levels of blood and effluent back. The citrate accumulation index, I told you, this total calcium multiplied by 0.25 divided by systemic ionized calcium, and it gives should be less than 0.25. That is 0.2.5. That is what we look at. And this was just I want to share what we discuss now. We start citrate with 3 millimoles per liter. But there are studies where people started with 2 millimoles per liter and they found no difference. So we need to give less citrate, but we need to understand how to give it. Okay, so we have to keep the fluid flowing. There should be no clotting in the circuit. The sieving coefficient should be within the range, but at the same time you have to give less citrate and you have to learn how to give it less. So what we follow is rule of 10%. There are no jumps into the flow rates. You started with a dialysate flow rate of say 1100 ml per hour. You can't go down to 700 ml. You can't go up to 1700 ml. The change should be within 10% only. So you can go up to say 1200. You go down to say 1000. Same for citrate. You are giving at 3 millimole, come down to 2.8 or go up to 3.2. No jumps. The moment you start jumping, the system goes haywire. You get very scary biochemistry on the panel. That is no role jumping, it is just rule of 10%. Go up or down by 10%. So this is for the Prismaflex multi-filtered platform. This is a very beautiful graph actually, I just loved it. So on the x-axis we have blood flow rates. On the x-axis we have, the flow rates of the Sika solution, the dialysate. On the y-axis we have blood flow rate. We want the patient to be within the green zone, where we have the serum bicarbonates in the range of say 26, 24, 22. We don't want it to go down to 18 or 20, that is the red zone. We don't want to go up to alkalotic range, which is 30 to 28. So how we achieve it? We achieve, if the patient is getting acidotic, we go down on the blood flow and we go up on the dialysate flow. Okay, this is just going up and down. We need more contact time. More contact time with the fluid which is going on the other side of the semi-permeable membrane. This is how we diffuse the bicarbonate in the Sika bags. And if we have this as a ready reckoner for our technicians, they can also use this. How to increase the Sika solution flow rate to match the acid-base balance of the patient. So 3 things are most important while do I have time? I'm running out of time, no? So these 3 things we need to understand: what is citrate dose, what is citrate clearance, what is citrate load. And these are the few equations where we understand that the citrate dose is determined by the citrate flow rate, the hematocrit, and the citrate concentration into the bag. Citrate load is always proportional to the flow rates. More flow rate, more citrate load. But the citrate load is inversely proportional to the effluent flow rate. So you have more citrate in patient's blood, you just increase the dialysate flow. Bring up the effluent rate, citrate will go down. There will be more clearance, so you don't have to bother about citrate. We can clear it very easily, okay? And this is how the citrate has 3 components divided into, which is citrate-bound calcium, albumin-bound calcium, and ionized calcium. What we look at is the physiological calcium, which is ionized calcium. We don't go by the albumin-bound calcium whenever we are running a citrate protocol. And so the calcium is the key. To the extent that people found out that what are the systemic effects of regional citrate anticoagulation in CRRT are determined by the fluxes in calcium. If calcium goes down, automatically the parathyroid gland gets stimulated. Okay, so there is some kind of a transient acquired hyperparathyroidism in patients if we make them hypocalcemic. Okay, so these were compared in multiple studies, and this has been proven that we need to keep the calcium as well as the phosphorus within range when we are running a citrate protocol. So this is something new which I could find. And there are controversies, of course. Circuit downtime, there is liver dysfunction we talk about, there is acidosis we are worried about. Just a word about acidosis. whenever the type of acidosis moves from a normal anion gap to high anion gap, that is the first thing you should suspect a citrate toxicity. The pH will not move, the bicarbonate will not move, the PCO2 will not move, it is just the anion gap which changes. That is the word of caution when we are running a citrate program. All right. Therapy cost. I just want to show you, when we started it in 2018, we were under tremendous pressure about the cost. So what we saw, we published this paper in 2020 Criticare Hyderabad. This was a poster which we displayed. We found out that the CRRT in citrate group cost 68,233 rupees per day to the patient, and heparin CRRT cost 52,796 rupees per patient. The p-value was 0.283, which was not significant. But when we looked at the circuit life or the filter life, it was significantly higher, which was 63.4 hours in citrate group and 46 hours for heparin group. So actually, we end up purchasing less dialyzers, we end up purchasing less filters, which costs around 20,000 rupees when we are using citrate. So actually the cost balances out. More filter life, but little costly therapy. And so what is recent? So now we are having calcium sensors built into the CRRT machines, which will help us get the display of calcium on continuous basis. We don't have to send the blood samples to lab. We don't have to ferry the samples to the ABG machine and get this calcium. But it will give us on a real time basis. So this is something I could share with you. So in conclusions, the contraindications to start regional citrate are few and they are relative. And that has to be done on case-to-case basis. More we do, more we learn. We are on a steep learning curve for citrate program. As of now, we are all learning. But that is all that I have for today. Thank you so much.
Thank you, sir, for that excellent presentation. Citrate, or for that sake, anticoagulation remains Achilles heel for managing CRRT program. And citrate, again, as you said, comes with many controversies and many confusions, basically. And the more we learn, more we are confident to use citrate. Question that I had was, many a patient when we are starting CRRT, especially having a chronic liver disease or cirrhosis decompensation, already have deranged INR or coagulation profile values. So how do you approach these patients to start them on heparin-free and citrate-free program, or we go with anticoagulation from the start?
So we just get an ABG. For liver dysfunction and raised ICT, we have CRRT as the modality of choice. We have to choose between three things, whether we are treating them with saline flushes, no anticoagulation, 2, heparin anticoagulation, 3rd, regional citrate. If the lactates are below 6, I will start citrate. Only thing, my citrate flow rate will come down. If I am starting with a 3 millimole per liter, I will go down to 2.5 millimole per liter for somebody who has a liver dysfunction or who has some structural liver abnormality like cirrhosis. It could be a decompensated CLD or a compensated CLD, that doesn't matter. To me, lactate is the Achilles heel, as you say. If lactates are okay, I start CRRT. There are few examples where, not in India, they could run Mars CRRT on regional citrate. So Mars is for a MELD C-score of more than 25. So they have invariably lymphatic dysfunction, but they could run it on regional citrate. So liver dysfunction is not a contraindication, it's just a relative contraindication.
Now the same patient whose lactate is say more than 6, 8 or 10.
Yes.
And the PT-INR is sky high.
Yes.
In such a situation, what will you do?
I stopped giving post-filter replacement. All the fluid which I am giving is pre-filter. So the patient blood is already thin. I don't have to make it any more thinner. Okay, the INR is gone up. This is not going to clot, but I am worried about the filter fouling. The filter should not foul with the proteins and it should not clot. So what I do, I bring down the post-filter replacement or I entirely stop it. The post-filter replacement, why I give is to prevent blood coming in contact with air. I have to fill the venous chamber to the full so that there is no blood-air interface. There should be blood-water interface. So I will give minimal 250 ml or 200 ml of replacement post-filter, and maximal replacement I will give pre-filter. So my filtration fraction comes down to 18 or 19. It doesn't clot. I don't have to give any saline flushes. Because saline flushes which are given by the technicians, they don't remove it. Patient gets volume overload. So 100 ml saline flush given per hour ends up to 2.4 liters of positive at the end of the day if you don't take it out. So I will use pre-filter, most of it pre-blood pump, and very minimal post-filter. This is how we'll go about if I am withholding citrate.
Any more questions from the audience? We can have Jairaj.
Coagulation during plasma exchange.
Plasma exchange, we usually give heparin because plasma exchange we are presently doing in two modalities. One, incorporated into the Prismaflex platform, that is one. Second, we do membrane plasma exchange. The centrifugal plasma exchange is taken over by the transfusion medicine, so we don't get into that. But heparin is the choice to start on plasma because it's a 3-hour therapy, and the P2 filter, Fresenius P2 filter is quite good, so we use heparin only.
So another question, may how do you assess weight of the patient who's on CRRT?
Yeah, that's a very interesting question. So what we believe on three things. One is ER weight. There is ER weight. Patient comes to ER, we have told our ER physicians to get the weight checked. If patient is very moribund and is not able to be weighed, we ask the historical weight. Ask historical weight, then we assess the patient clinically. If the patient is having only sacral edema, patient is 4 liter positive. If patient is having pedal edema as well as sacral edema, patient is 7 liter positive. If his patient is gross anasarca with abdominal wall edema, patient is 11 liters positive. So that is the patient's weight what we consider. We do not go by ideal body weight, we go by the actual body weight because that tells us the volume of distribution. If we go by the ideal body weight or the dry weight, we end up giving less antibiotics, we end up giving less effluent dose, we end up giving less sedatives. If we go by the actual volume of distribution, because whatever I am giving, it is getting distributed into the entire body, that is not getting into the intravascular, it is getting interstitial also. So we go by this algorithm, but this is very arbitrary. This is just through experience what our teachers told us, but this is how we go by. We are pushing very hard to get weighing beds for ICUs. Few closed ICUs, they have weighing beds. That is very fantastic because we could see that the cumulative fluid balance is affecting the outcomes of the patients. And to do that, we need weighing beds. But at least my center doesn't have it. But that's a very well taken.
Thank you, Dr. Girish, for that excellent presentation. Thank you.
Thank you, sir. Now I request the respected chairpersons to present the memento of appreciation. Dr. Girish Kumtekar, sir. Further, I request Dr. Jeswani to present a token of appreciation to chairpersons. Thank you, chairpersons, and thank you, Dr. Jeswani. Now it's time to move on to the next informative session. In critical patients, CRRT is frequently used with other modalities like ECMO. To share her valuable insights on the topic, we have our next eminent speaker, Dr. Vinita Goyal ma'am. To chair this session, I please request Dr. Utkarsh Deshmukh sir and Dr. Jairaj Korpe sir to please take the seat. Dr. Utkarsh Deshmukh sir is a consultant nephrologist at CARE Hospital, Nagpur, and Dr. Jairaj Korpe sir is a consultant nephrologist and transplant physician at Korpe Hospital, Akola. Over to the chairpersons.
Hello. Yeah. Dr. Vinita Goyal, madam. She has done MD anesthesia, MBBS, IDCCM, EDIC, and she's at present heading the unit at critical care center, and she has specialties in ECMO, infectious diseases. She has enormous experience as a consultant in the ICU and at the Fortis Escort Heart Institute for more than 10 years. So over to you, ma'am. Thank you.
Thank you, sir. So moving on from kidney to heart and lung. So we all know that almost 60 to 70% AKI in ICU is due to heart and lung problems. So in my talk, I'll be focusing on these three topics, a general overview of ECMO and ECOR, and a bit on the CRRT on ECMO. So we all know that in CPR, there is a role of high quality CPR and defibrillation. In 2010, first ECMO was put for cardiac arrest when conventional resuscitation did not work, and the patient survived. In 2012, they did a pre-hospital ECMO for the first time, and now it is well established that eCPR has shown good results and the survival rate is also high. So there are two modalities basically extracorporeal. One is for the oxygenation and one is for the carbon dioxide removal. As we go forward, basically I just want to give you a background on where ECMO and ECOR like modalities come into place. So in ARDS, we all know that it is a heterogeneous disease. So a lot of studies have shown that we need to cut down on the tidal volume and the pressures generated to avoid any barotrauma. So the ARDS net protocol, it says that 6 ml per kg predicted body weight should be sufficient to keep the plateau pressures less than 30. And this is the only level evidence that shows that works in ARDS as a mortality benefit. So if we go down to 6 ml per kg body weight in ARDS, there is a high chance that the carbon dioxide may rise because we may not generate too much of minute volume to avoid any barotrauma. So then they said, okay, proning may be one of the things, muscle relaxant use. Many studies came, Proceva trial showed that there was a survival benefit with proning. But still after proning, if the patient doesn't improve, what next? So now with the Caesar trial and the Aeolia trial, a lot of new trials which have come up, there is a high survival rate with ECMO in ARDS. So the ELSO registry, European Life Support Organization, it has a lot of database on ECMO, and almost 50% survival rate was shown in 2013, and it just keeps increasing every year. eCPR also, the data has shown a lot of benefit. A bit on the history of ECMO. This is the first ECMO machine which was used by Dr. Gibbon for open heart surgery. Many attempts were made, but the survival was very low. Then in 1975, a breakthrough came when Dr. Bartlett, who is known as the father of ECMO, he put ECMO for a meconium aspiration in an infant, and the baby survived. And he also showed that the circuits could run for a longer time with heparin without any with good hemocompatibility. And this is the first baby, and in the next photograph you can see her with her daughter who came in the ELSO conference, and it was a very proud moment for everyone. In 2009, with the H1N1 pandemic, we saw a surge in ECMO, and the centers, the expertise kept on increasing. And in latest 2021, after the COVID experience, I think many centers are now doing ECMO with a lot of expertise, and the numbers have risen exponentially. A word on the CSER trial, which was a landmark trial, and it showed, actually this trial, it was done in UK, and it showed that early referral, after trying all the optimum ventilation strategy, the early referral to an ECMO center actually increased the survival rate. So 90 patients were, they enrolled a lot of patients. So the crux of this study was that 90 patients were referred to the ECMO centers, and 90 patients were put on the conventional optimal ventilation strategy with proning and everything. And they found that there was a remarkable 6 months survival without disability, which was shown. So they recommend transferring of adult patients with severe but potentially reversible respiratory failure. Now, reversible is a very important word here. As we go further, I will explain to you. To a center which is ECMO-based management protocol shows significant survival rate. So what is an ECMO device? What are the parts of an ECMO machine? There is a centrifugal pump. There is a console which shows you the values that you set, the RPM and the blood flow rates. There is a gas blender which mixes air and oxygen, and you can set the sweep gas on that for the carbon dioxide removal. And there is a humidifier, heat exchanger. Here you can see the first photograph shows a centrifugal pump. The next is the heater cooler and the gas blender. You can set the FiO2 on the silver knob here, and this is for the carbon dioxide removal, the sweep gas. This is the console where you set the RPM, and it gives the liters per minute of flow you want from the patient. And this is the ACT machine. This is the oxygenator. Now, oxygenator is somewhat like a dialyzer. It has a membrane, and on one side there is a blood inflow from the patient, and on the other side there is sweep gas which passes, and then there is the exchange. As you can see here, this is the membrane. The blood comes from the patient. It is pumped out. It flows here, and the sweep gas from the blender enters there on the other side, and there is exchange of carbon dioxide and oxygen, and the oxygenated blood comes out. The gas exchange for oxygen is determined by the blood flow. So it is very important to understand that the membrane characteristics and the blood flow, the rate of the blood flow determine the oxygenation. And obviously the FiO2 that you have set in the oxygen blender. Whereas for carbon dioxide, it is the sweep gas flow which determines the removal of carbon dioxide. Now, how should we plan our ECMO? So there are a few questions that one has to ask oneself. That is the life-threatening condition cardiac or respiratory? So are we planning a VV ECMO for a cardiac, VA ECMO for a cardiac condition, or we are planning a VV ECMO for a respiratory support? Are there any comorbidities? Is the condition reversible? Because obviously this is not the destination therapy. You have to have a plan after you have put the patient on ECMO. Then is ECMO better when you weigh risk versus benefit ratio? Or if there is a likelihood of bleeding or developing or worsening coagulopathy on ECMO, which may cause catastrophic bleeding and the patient may die. This is a typical ECLS circuit with a bifemoral approach. The blood is taken from the IVC through the femoral venous cannula. There is a pressure transducer here. So this is usually negative pressure. With negative pressure, you draw the blood out, almost -50 to -150. And this goes to the pump, centrifugal pump, which throws the blood out. There is a flow sensor here. So whatever flow that is flowing in this, according to the RPM, it gives you the value is given on the console. Then there is this P2, which tells you the pre-oxygenator pressure, and P3 is the post-oxygenator. So this is the oxygenator, and there are the two P2 and P3, pre-oxygenator and post-oxygenator. So whenever we run an ECMO, we attach two pressure modules to this, and we monitor the pre-oxygenator and post-oxygenator. Why is it important? The difference of the two, pre-oxygenator and the post-oxygenator pressure, should be somewhere around 50. If your filter is clotting, if there is a thrombus, the pressure difference will start rising. So when you get a pressure difference of say around 100, you have to be prepared that there is something wrong with your oxygenator and your oxygenation may get hampered. So you have to start preparing and see whether your heparinization, ACT values are normal or not. Once it surpasses 150, the pressure difference, you have to change the oxygenator. So coming to the indications of ECMO, VV ECMO, it is very clear we are doing for oxygenation. So a PO2 of less than 80 after your optimal ventilation strategy, proning, everything. If your PO2s are not improving, you have to think of ECMO, and that has to be early. Trials have shown that before 7 days, if you do ECMO, the chances of survival are more. Hypercapnic respiratory failure, pH less than 7.20. Then also one can think of ECMO, or as a bridge to lung transplant. Now there are a lot of emerging indications for VECMO. Earlier, VECMO was done only by CTVS surgeons in the OTs when their patient was not coming off CPB. That was the commonest central ECMOs that we saw. But nowadays, ECMO has shifted to ICU, where eCPR, starting right from ER, the ECMO is being put. And the commonest indications we see is myocarditis. And obviously, toxicology, drug intoxication like sulfurous poisoning, where it has shown very good results. Otherwise, there is 100% mortality in sulfurs. So drug intoxication, and then arrhythmia storm. These are all conditions where acute pulmonary embolism, which have shown good results. What are the contraindications? So essentially, I think contraindications, there are a lot of absolute and relative, but for me, I think there should be no bleeding risk, very high bleeding risk. There should be no CNS injury. Post cardiac arrest, you should be, in a position to ascertain whether there should be no permanent neurological damage. An unwitnessed arrest may not be a good option for a eCPR. And again, the reversible nature of the injury. You have to have a backup plan. If the patient is waiting for transplant, or if there is a surgery planned, then one can think of ECMO. And as I told you, obviously mechanical ventilation for more than 7 days, one may still think that whether the patient will benefit or whether the survival would be that much or not. Cannulas, since it's a nephrology forum, I don't need to talk much about this Poisson-Hagen equation. We all know that the flow in the cannula is determined by the fourth power of the radius. So the more the diameter of the cannula is, the more flows. And as I told you, oxygenation depends on the blood flows. The more you can take out from the patient and circulate through the oxygenator, the more oxygenation you will be able to achieve. And it is inversely proportional to the viscosity and the length of the cannula. Cannulation approaches are basically, in VV ECMO, there are 3 cannulation approaches. One is either you take the blood from the femoral and return it to the internal jugular, or you take from the femoral and return it to the femoral vein only. Third one, which is used in many centers where you want an early ambulation or the patient is waiting for a lung transplant, there you put a bicaval dual lumen cannula. So it looks like this. The cannula has two lumens. One carries the deoxygenated blood from the SVC and IVC to the oxygenator, and the blood which returns from the oxygenator carries the oxygenated blood. But one thing which is to be noticed is that it is very important that this cannula is put under fluoroscopy or transesophageal echocardiography, because it is very important to have the opening of the return towards the tricuspid valve. If it is anywhere else, it may cause a lot of problems. So placing this cannula may not be very easy in ICU. But yes, definitely the mobility of the patient is much better with this cannula because there are no femoral cannulas placed. You can see in this X-ray, this is the bicaval double lumen cannula. And this is the femorojugular approach where you drain from the IVC, pass it through the oxygenator, and it returns into the jugular vein. The thing to be noted here in a double lumen is that the distance between the tip of both the cannulas, the femoral and the jugular, should be at least 10 to 15 centimeters. Otherwise, there is a high chance of recirculation. So what will happen? Whatever oxygenated blood comes from here will go back, some percentage of it will again go back into the drainage cannula. So the distance between the two has to be at least 10 to 15 centimeters. Configurations of VA ECMO are two. One is the peripheral and one is the central. Central we won't be dwelling too much on because it is mostly in the CPB situations where one is not able to wean. Blood is taken from the right atrium directly and returned to the thoracic aorta. Whereas in the peripheral ECMO, it is basically a bifemoral approach where the blood is taken from the femoral vein, passes through the pump and the oxygenator and returns back to the femoral artery. One thing that needs to be remembered here is that there is a high chance of limb ischemia in VA peripheral ECMO. So you have to have a distal cannula, perfusion cannula in place. We'll just discuss that shortly. So, yeah, one thing, why we want to do VV ECMO in ARDS. So hypercapnia, as I just told, that with the lung protective ventilation strategy, we have a high chance of developing more carbon dioxide retaining. Permissive hypercapnia is maybe not so good. So nowadays there is a concept of ultra protective lung ventilation where they say that carbon dioxide increase causes respiratory acidosis. Acidosis causes pulmonary vascular resistance to increase. And so it may cause decreased myocardial function and decreased cardiac output. So that is why one has to take care of the carbon dioxide, and nowadays permissive hypercapnia may not be so good for the ARDS patient. So how do? We do it under ultrasound guidance. I have told the accesses, flows, we have to get good flows according to the weight of the patient. We decide the blood flows. Almost 60% of the cardiac output one should determine to get. And your gas flows should be as per your PaCO2. So your targets of carbon dioxide would be somewhere around 35 to 40. So you can set your sweep gas flow to keep those. And yes, obviously anticoagulation is a very important part of ECMO, and with heparin one can monitor the ACT somewhere around 180 to 200 for VV and 180 to 220 for VA ECMO. And the ventilation settings should, after once you started the ECMO, your ventilation settings should go down to ultra protective. So maybe 3 ml per kg of body weight and low respiratory rate, low PEEP to avoid and give lung total rest. So what is the monitoring that needs to be done on ECMO? Oxygenator function, as I told you that pre-oxygenator and post-oxygenator pressures are very important. As they start going up, you know that there is some problem in the oxygenator, clotting or something. Then pump function. Pump is very essential. If there is any air coming inside the pump stops functioning, then it may be a problem. So you need to have a hand crank. So there is a pump attached on the ECMO machine which you can actually run by rotating it by hand. So this hand crank should always be available. Then HIT, obviously we have discussed it earlier. HIT is one of the other things that one may come across. So bivalirudin, or you can use argatrobin if there is renal failure for these patients. ABG, always try to get a right radial arterial line. I'll just explain to you why it is important to have it in the right radial. Then deep venous thrombosis, limb ischemia causing compartment syndrome, fluid creep, daily chest x-ray for position of cannulas, secure cannulas properly, because if they get dislodged, then we are in a mess. Collapse of the lung is also one of the important things. So hypoxia occurring on ECMO, we'll just discuss that, is one of the reasons for that could be collapse or new infiltrates developing on the lung. And therapeutic drug monitoring. As we are doing an extracorporeal circuit, there is bound to be antibiotic losses, so we need to adjust those. Now, problems specific to VA and VV ECMO, just a few slides on that. We all know this equation, we have read this in our physiology. Oxygen content of the blood is determined by 1.34. This is just slight maths in this. This is the only slide which has some maths in my presentation. So 1.34 into hemoglobin into the saturation of the oxygen. So oxygenation is a function of the saturation, which we can actually adjust with the ECMO, as I told you, the blender and the ECMO knob that we have on the blender. Pump flow, cardiac output is determined by the pump flow. So the surrogate for cardiac output is pump flow. The more blood flow that we get out of the patient pass through the circuit and oxygenator, the better chances of oxygenation. And increase hemoglobin. As we know that the oxygen delivery is dependent on the hemoglobin. But now, earlier the transfusion trigger on ECMO used to be 10, but now it has come down up to 7. So we are accepting a hemoglobin of 7, and patients are doing well on that to avoid unnecessary blood transfusions. Now, hypoxia on ECMO. What are the reasons for a patient having hypoxia on ECMO? As I told you, the blood flow. Any problem with the drainage can cause less blood flow. So if sometimes what happens, X-ray technician comes to take X-rays, he'll just put his trolley there and the wheel might go on the ECMO pipe. So there may be access insufficiency, or there may be some kinking or clot or air bubble. So all these things can cause the blood flow to be decreased. As I explained to you, recirculation. If the cannulas are too close, tip of the cannulas are too close to each other, then setting of the gas blender and FiO2. Low hemoglobin. Any change in cardiac output, like in a sepsis patient, if there is a myocarditis or Takotsubo cardiomyopathy develops, then one may expect the hypoxia to happen. And substantial change in the ventilatory settings due to some collapse or pneumothorax occurring. So we have to actually keep all these things in mind. How recirculation is the phenomenon observed during VV ECMO, in which a portion of the reinfused blood from the circuit is returned immediately back to the drainage cannula. How can we do to correct the situation? Just reposition your cannulas by pulling them so that there is a 10 to 15 centimeter difference between the two. And bronchoscopy if you have some infiltrates or collapse of the lung. See here, you can see that there is no space between the tips. They are just meeting here. When you reposition, the upper cannular tip is here and the lower cannular tip is here. The other one is north-south syndrome, which we call Harlequin syndrome. It is seen in peripheral VA ECMO. You don't see this in central. Why it is seen in peripheral? What happens is, see, in VA ECMO, when you return the blood through the femoral, and there is some native cardiac output also. So usually when the ECMO flow is high and the cardiac output is less as the heart is failing, the point where these two meet is slightly proximal. So there is no problem. But as the heart starts improving, but the lung is still bad, okay? The heart starts improving, this meeting of the native cardiac output and the blood that is coming from the ECMO cannula will go down somewhere here, because the cardiac output is also now improving. So what happens is the upper part of the body, which is getting blood from the native heart, what happens is that will be deoxygenated, because it will go through the pulmonary capillaries and then go to the upper part of the body. So the lung, as there is oxygen transfer is less in the native part of that, there is poor oxygenation, whereas the lower part of the body will get the blood from the ECMO oxygenated blood. So there is a difference between the upper body and the lower body, and this is known as the Blue Man syndrome or the Harlequin syndrome. So in addition, relatively higher oxygen extraction occurs from the upper body, cerebral and coronary. So even lower oxygen return in the venous blood. So that is why if you put a right radial cannula, you will see the PaO2s would be less in your, or the saturation would be less in your upper body, arms, but whereas if you put your saturation probe on the toes, you will see that the saturation is 100%. So that is one way of diagnosing Harlequin syndrome. How do you treat that? So you put another cannula. What you do is, this is called the hybrid therapy, VAV cannula. What you do is, the blood which is returning through the lower ECMO cannula, you divide it into two parts. You put a Y connector here and you transfer some amount of blood from this to the upper part of the body and return it, put another cannula in the right atrium through the internal jugular vein, and you return some part of the oxygenated blood to the upper part of the body. When this goes out to the coronary and cerebral circulation, this will take care of the upper body oxygenation. So that is how we counter the north-south syndrome. It is very easy. You just put a clamp here, put a Y connector, put a one more cannula in the right atrium, just divert some amount of blood flow back into the right atrium, which goes into the upper part. And the lower part is still getting blood from this part of the aorta. Another problem, which is very importantly seen in VA ECMO, is the LV distension. What happens is, after a few days on ECMO, VA ECMO, you see the X-ray going white and you don't understand what is happening. So this patient develops pulmonary edema. Why? Because VA ECMO is a non-pulsatile state. What happens is, the LV just keeps filling by the Thebesian and the bronchial vessels. And since it is not pumping, little by little it starts distending and it causes back pressures to the pulmonary circulation and it increases. Since there is a lot of ECMO flow, which is coming from down and causing pressure, this heart is having an increased afterload. The heart is already not working properly and it is not able to counter this afterload increase. So this distends, causes pulmonary back pressures, and there is pulmonary edema. So how do you counter it? Either you decrease the ECMO flows so that the afterload goes down, or you may vent the left atrium or the left ventricle, or put in an IABP, anything to decrease the afterload. The targets on ECMO, I'll just briefly say these. The saturation, obviously we all know the idea is to keep the tidal volumes less, up to 3 ml per kg, and avoid barotrauma. PaCO2 35 to 40. Anticoagulation up to 180 to 200 in VV and 200 to 220 in VA. Sedatives, yes, now we don't give too much of muscle relaxants and sedatives. First day we do use sedation. From next day onwards we stop sedation and try to bring this patient out, because there is a high chance of critical illness, polyneuropathy. Fluid balance, the key to successful ECMO is negative fluid balance. The more we give fluid, more fluid creep occurs and the chances of coming off ECMO are very poor. So there is excessive capillary leakage phenomenon in critical illness patients, and we have to give a fluid restrictive approach. Renal failure may worsen because of hemolysis, sepsis, multifactorial causes could be there. Antibiotic therapy, definitely ECMO has a heat exchanger. So the patient may not develop signs of fever, all these things. Already he may have leukocytosis because of the exposure to the extracorporeal membrane. So all these conventional things may not tell you that the patient is actually having sepsis. So dose of antibiotics should be adjusted according to the pharmacokinetics and dynamics on ECMO. Now, how do you wean the patients off ECMO? So veno-venous, see, it is very simple. For whatever reason you are putting the ECMO, that has to reverse. So the lung has to get better, your chest X-ray should be better, and your ventilator settings should be able to manage the low protective ventilation strategy, keeping a saturation over 90. So you go down on your ECMO FiO2, you go down on your sweep gas. You don't need to decrease blood flow for veno-venous. So you, as you go down on your sweep gas up less than 1 liter and the patient does well, then you can come off VV ECMO. Similarly for veno-arterial, there is hemodynamic stability. The chest X-ray is good, your lung functions are better. Your echo shows good improvement. You may not have a very high cardiac output, but at least your lactate levels have settled down. So you can decrease the blood flow. That is how you wean off VA, by decreasing the blood flow to 1500 RPM. If the patient does well, you are good to come off ECMO, veno-arterial. How do you troubleshoot? So routine ECMO problems could be access issues, as I said, kinking, thrombus, air bubbles, flow fluctuations, kickback of the venous line. Now sometimes we see that the patients are hypovolemic and there is line chattering. So there is, the line shakes. So that tells you that there is hypovolemia and you need to give fluid to the patient. The disadvantage of not recognizing this and continuing without giving fluid would be hemolysis. Excessive line chattering can cause hemolysis. So limb ischemia and bleeding. So how do you counter limb ischemia? This is a complication of VA ECMO. So when you have put a VA ECMO, this is, one should always take care to put this distal perfusion cannula. So as you can see, your arterial cannula comes like this towards the heart. So you put another 6 French or 7 French sheath and you connect it from the venous, from the arterial cannula to back to the, you give blood back to the posterior tibial and the lower arteries to maintain the circulation in the limb. So it is ultrasound guided and one has to check daily for the pulses. You can put a saturation probe and see whether your limb is warm and getting good supply of blood. Now catastrophic problems could be decannulation of the cannula. Suck down can occur and there could be circuit rupture. These are all catastrophic like that. So there is very essential to have these clamps on the ECMO cart. As soon as anything like this happens, first thing first is you just clamp so that there is no exsanguination of blood from the patient. Coming to ECOR. So ECOR is, why, just background of this. Again, ECOR is one therapy which is for ultra protective lung ventilation. As I explained earlier, when we do conventional, up till now we were being told 6 ml per kg, plateau pressures less than 30 works well for us. Maybe you can accept a bit higher carbon dioxide for that. But now, with lot of studies, they have shown that carbon dioxide is actually not good for the right heart. Acute cor pulmonale occurs and you may actually cause the patient to go into hemodynamic instability. So for that they say you put Accor and go down on the tidal volumes further to avoid any barotrauma, and that is ultra protective lung ventilation. Another thing that they said was in COPD, acute exacerbations or asthma, where a patient is not doing well on non-invasive ventilation, if you put an Accor, the chances of him going on mechanical ventilation and through all the infection and the complications, the barotrauma of mechanical ventilation in a COPD patients can be just mitigated. So indications essentially are respiratory failure from ARDS and exacerbations of chronic lung disease, where you can change your failure of NIV to success by putting an Accor, and the need for ventilation may not even arise. So there are two systems. One is the pumpless, which is not used that much, and one is the pump-driven system, where you have roller pumps, and ECMO circuit is just similarly what I explained. It takes the blood from the patient, it goes through the pump, through the oxygenator, and is pumped back into the patient. The advantage of Accor is that it requires very low blood flows. So almost only up to 250 ml per minute is required, and you can actually incorporate the oxygenator in the dialysis machine. So these are the components, these are the cannulas. You can see that the cannulas are very small. You don't require very large, thick cannulas. This is the pump, the oxygenator. There is a blood flow inlet. There is a sweep gas flow inlet. Then outlet of the sweep gas, blood flow outlet. And this is for the flushing of the oxygenator. This is how it is assembled. And this is the console. This is the oxygenator which is available. These are usually pediatric oxygenators. If you use the conventional adult oxygenators, at such low flows, there is a high chance of thrombosis. So these are special oxygenators which are coming. It is called Lilliput by Soren, which is available in India, and it can be used. So the advantages are low flow rates. They are logistically simpler, the economic burden is less, and not very long runs happen. So I have already explained the rationale behind Accor. There is, wherever you have increased ICP, there also you don't want hypercapnia, there also you can use Accor and achieve tidal volumes of less than 3 and plateau pressures of less than 25. So COPD, we know that worsening dynamic hyperinflation, ventilation perfusion mismatch, all these things. This was this study, extravent study, which showed that actually lower tidal volumes were even better in severe ARDS by putting Accor. So yeah, indications we have already discussed. PKPD of drugs, we all know that there is interaction with the ECMO circuit, sequestration, lipophilic, hydrophilic drugs. Metabolism is removal and clearance of the drugs is affected. Want me to go on? Just 2-3 slides more. CRRT, do I have time? So CRRT and ECMO. So there was this acute dialysis quality initiative which came up, and it said that there was no evidence of preemptive RRT in ECMO. So there is the only thing which works in ARDS is lung protective ventilation strategy, fluid restrictive strategy, and avoidance of any infections. Other than that, there is no role of putting patients just for the sake of fluid removal on RRT. So this is how we integrate ECMO with CRRT. So AKI, we all know what are the reasons. The indications, essentially fluid removal is the main indication for incorporating CRRT with ECMO. So there is this Prisma lung. I guess it is going to be launched next year in India, and it is going to change the face of Accor. So this is by Baxter. So this paper on lung-kidney interactions, it tells that we recommend initiation of CRT should be based on absolute and relative indications, given there is no evidence of benefit for combining ECMO with preemptive use of CRRT. Now, what are the concerns with CRRT? CRRT access is usually connected post-oxygenator. So to make it clear, whatever is pre-pump is negative because you are drawing blood from the patient. Whatever is post-pump, it is positive, and the positive pressure just keeps increasing. So if you connect CRRT post-oxygenator, it has a high positive pressure and it is going to be delivered to the CRRT machine, and it may cause a pull on the, so you have to set the alarms, change the alarms on the CRRT device. Then the CRRT return line, so whatever you are returning from the CRRT has to be returned pre-oxygenator, because if there is a bubble trap, air bubble, the oxygenator will trap it and you can remove the air bubble. If you place the line beyond the oxygenator, the air bubbles will straight away go to the patient. So just remember, anything which you return back from the CRRT machine has to be pre-oxygenator. Now, as I told, line chattering could be because of hypovolemia, so you can just decrease your fluid removal if it happens on CRRT. These are the ways how you connect. So you can see the color difference. This is red, so this is post-oxygenator, and this is the pre-oxygenator part of it. So you return the blood pre-oxygenator and you access or drain to the CRRT post-oxygenator. So essentially there are a lot of configurations, 7 or 8 configurations to connect CRRT with ECMO. But essentially I'll just talk about 3 configurations. One is the access is post-pump and the return is pre-pump. So this is pump, this is not oxygenator. So what is happening is, here is your pump, patient, the blood is drawn from the patient. There is negative pressure here, and post-pump there is positive pressure. So what you are doing is, you are taking blood from here, passing it through the dialyzer CRRT machine and returning it back pre-pump into the negative pressure system. But the drawback of this is that if there is any air which is here, it may cause the pump to stop. So you have to be very careful. Another configuration is that CRRT machine is attached separate from ECMO. So you just put a dialysis catheter which is separate. You don't have any connection with the CRRT and the ECMO machine. The problem with that, the ease with that is that you don't require a transfusion, perfusionist or anybody to actually run. There are 2 separate models which are running separately. But the problem is that you will be putting in a separate cannula on ECMO where the ACT may be high and the chances of bleeding may be high, and the chances of infection and mechanical complications of putting in another cannula may occur. Third configuration is where pre-oxygenator, so just as I explained to you, that the blood is taken post-oxygenator and returned pre-oxygenator from the CRRT machine. And there is no need for separate anticoagulation, and as sir told, that if you are using citrate, your heparin dose will go down. So long-term prognosis, we need not. So now the key to success, we have to remember that the time of initiation should be early. As soon as you realize your patient is not doing well on conventional optimal ventilation strategy, take the decision to put on ECMO as soon as possible. The more number of days you lose, the less chances of survival. Appropriate selection of patient. More than one organ failure, there is a high chance of non-survival. Organ support. What are the other organ supports that the patient is on? Risk of anticoagulation, always see whether the patient has a high chance, any malignancy, anything else which could lead liver failure. Non-reversible pathology, it is a no-no for ECMO. You don't have to carry on with the morbid condition on ECMO. Explain to the family that nothing can be done rather than putting ECMO and just prolonging the suffering. Run-in days of ECMO, the more days you are putting the patient on ECMO, the less chances of coming off ECMO. So always have a backup plan. And sepsis could be one of the reasons for non-survival. This is my team of ECMO at Sarvodaya Hospital. We have an ECMO specialist, which obviously it's run under me. Doctors, nurses, perfusionists. These are my perfusionists, without whom we cannot have ECMO in place. And I am sorry if there is a surgeon here for putting him last on the list, because we need him only for catastrophic complications, which till now, touch wood, we have not encountered. This was recently a patient which we had put on ECMO. He was a CLL with immunocompromise, had been on steroid for last 6 months, high dose steroid. He came with Legionella pneumonia, and he did well, was discharged, and thankfully the family was quite happy, and the oncology team was quite happy. Thank you for your patient hearing, and any questions, I'm happy to take.
Ma'am, first of all, thank you so much for simplifying such a complex topic on ECMO and ECOR. Second thing, I have a few questions.
Yeah, sure.
Like, how do you really match the blood flow rates while taking a single circuit for ECMO as well as CRRT?
So actually, sir, we have to. It's not about the flow. So ECMO, normally the VA ECMO and the VV ECMO, the flows will be high. So we have to change the pressure targets on the CRRT machine. And the configuration actually is oxygenator, pre-oxygenator and post-oxygenator. So that is the most successful configuration that we have seen apart, out of all the things. If for some reason, sometimes if the patient is already on CRRT and there is a high chance that the circuit may clot, we put a separate ECMO, separate CRRT cannula. We don't actually incorporate it into the system. But otherwise, it is very efficient to run. We just, if we are anticipating, we just provide the inflow and the outflow 3 ways, and it is very easy to connect through that. So what we do is, while connecting, you connect with one 3-way, you have a syringe filled with saline, and you just wash out all the air bubbles and simultaneously just connect it. So, and change the alarms on the CRRT machine for that. Okay. So it works well.
Great, thank you. Another question, ma'am, which is the preferred mode of ventilation during ECMO and vis-a-vis during using ECOR?
Actually, there is none of the, it has not been shown to, any of the modes have not been shown to be better on each other. It is just the ease and the expertise of the person who is operating. If I am more comfortable with pressure control, I may put the patient on pressure control. If somebody is more comfortable in volume control, they may choose for volume. The whole idea is to have a tidal volume which is less than 3 ml per kg, and your plateau pressures should be less than 30. So that is the main target.
Thank you so much.
So, ma'am, I have one question, that we all know that the AKI which occurs in ECMO is secondary to shear and stress and that hemolysis. So what are the things to be done to minimize the acute kidney injury during this ECMO?
So there is, one is preload, contractility, afterload. These are 3 things. If we see preload, as I told you, if you are seeing, there are 2 aspects of it. I don't want fluid creep. I don't want hypovolemia. Right. The more line chattering, the more hemolysis, more plasma hemoglobin, more. Compartment syndrome, I keep my pulses in place. There is no rhabdomyolysis. So there is no pigment which I am getting. Sepsis, good control of sepsis, good control of my fluid, capillary leakage and mechanical ventilation. The whole idea of avoiding lung distension is to decrease the, to increase the cardiac output and decrease the afterload. As the cardiac output improves, the kidney perfusion will improve. So if I go down on my intrathoracic pressures by putting these modalities in place and decreasing the tidal volume, I am increasing the cardiac output. And that is again helping my kidney perfusion. So my contractility, my preload is taken care of. Afterload, again, as I go down on the intrathoracic pressures, contractility, hemoglobin up to 10, oxygen delivery better, rest will work. So everything is like multifactorial. I have to know what is causing AKI and treat it like that.
Thank you very much. So session is open for the question.
Nowadays, proning is standard of care in ARDS patient. So if patient is not responding to proning, then we have to go for the ECMO. But there are some patients, madam, even if after response to proning, after 2 to 3 days they go down because of the villi. So is there any role of preemptive role of ECMO in those group of patients?
See, ECMO, having talked about ECMO, one thing which is my responsibility to tell young doctors like you is ECMO is, it may sound very easy, but it has a lot of things, which you have to take into consideration. One is the financial burden on the family. You have to be satisfied that you have tried enough without ECMO and then convince yourself that yes, my patient is not improving on proning. I have done everything ventilation wise, my ventilator settings are optimum. The lung pathology, is reversible. There should be no fibrosis. Like COVID, we saw a lot of patients were being put on ECMO, but there was no survival advantage. Many of them did go to lung transplant, but yes, essentially you have to have that notion in mind that my lung pathology should be reversible. So speak with the family, explain to them the risk of bleeding, sepsis, long run, finances, everything. And then the earlier you take the decision, once you have tried proning, 1 or 2 sessions of proning, it is not working, saturation is down, you are not able to ventilate, you have seen there is no collapse, no pleural effusion, you have worked all that out, you have drained the pleural effusions, you have treated the collapse by doing bronchoscopy, you go for ECMO. The sooner you put, the better.
Thank you, ma'am.
So I think we should conclude the session. Thank you, madam.
Thank you, ma'am, for this informative talk. I would request the chairpersons to present the memento to Dr. Vinita Goyal, ma'am. I would like to request Dr. Faizan Ansari to present token of appreciation to our chairpersons. Thank you, chairpersons, and thank you, Dr. Faizan, sir. Our next lecture is on the topic sepsis management and adsorptive filters, for which I would like to invite Dr. Rushi Deshpande, sir. I invite the chairpersons for this session, Dr. Ashwini Kumar Khandekar, sir, and Dr. Sureshri Pandey, madam. Dr. Khandekar, sir, is a senior consultant nephrologist and transplant physician at KIMS Kingsway Hospital, Nagpur. Dr. Pandey ma'am is a consultant nephrologist and transplant physician at Wokhad Hospital, Nagpur. Now I hand over the session to the chairpersons. Thank you.
Good afternoon, everybody. Dr. Rishi is a familiar face to all of us in the West Zone. He is a teacher at heart. He is attached to Reliance Foundation and Jaslok Hospital. He will be talking on the fancy filters that one wants to use, hopes to use, is not sure about whether they are going to be useful. It is probably like the keto analogs of critical care. The fraternity is divided into believers and non-believers. So let us hope he converts all of us into believers. Over to Dr. Rishi.
Thank you, Dr. Pranav and the Nephrology Society of Nagpur for the kind invite. Thank you, Dr. Ashwini, for the kind introduction. You know, sometimes you come to teach and you go back having learned something. So that is like a typical day today. Having heard all the speakers from the morning, we had a lot to learn. And I really thank all of you for having me here to talk about what is quite close to my heart, about sepsis management and adsorptive filters. So what is a nephrologist doing here talking about sepsis? And why do we need a nephrologist to be involved in sepsis care? So what is sepsis is known to all of us. Primarily we are talking about an exaggerated response to the PAMPs and the endotoxins. And that is leading to the elevated toxin cytokine levels, leading to our need. So basically we are not talking sepsis, we are talking septic shock. We are talking about a life-threatening, time-dependent condition where the risk of mortality with all the treatments available is 56%. So when we are talking about organ involvement, 1, 2, 3, I mean this audience doesn't need me to tell that the mortality of sepsis is still unacceptable in our ICUs in spite of the standard of care. Whatever scores you use, whether you use the SOFA score or better, if you can use a CRRT or a new score, whatever you use, you need to understand that you need to pick up these cases very early if you want to make any change in their outcome. Waiting for the next day is not going to be a way of treating these patients at all. And what do I mean by that? Look at this, the ICU guidelines. In 2005, they were speaking about a 6-hour resuscitation bundle. In 2018, it has gone to a 1-hour bundle. Why do you think this is happening? It's because the rate of mortality remains unacceptable when you are trying to have a 6-hour bundle and you say that within 6 hours if I do, I'll achieve success. You don't. So we have come down to a 1-hour bundle now. And I'm going to tell you what we are going to talk about. So before the RRT, everything is standard. All of us do that in the ICU for our patients, right? We try and control the source control for sepsis. We try and find out the bug. We try our best to deliver the optimal doses of all the antibiotics that we should. Support the patient, support his organs, oxygenate him, ventilate, maintain the pressors, etc. Now, RRT, as it stands even today for most of us, is basically something that is an organ support when the kidneys are not functioning optimally. So these modalities were discussed in the morning about whether we are doing a intermittent, hybrid or continuous. But for some of us, when we say SLED and we do a 24-hour SLED, we are adding a lot more to the algorithm here, right? So it is not the type of dialysis, but the timing of dialysis. That is kind of something crucial that is coming out of all these discussions. Modalities, again we have discussed basically whether we talk convective clearance or diffusive clearance. When it comes to management of sepsis, we are not talking diffusion. When we are talking about organ support and urea removal, we are talking diffusion. So that is the central difference between the two. Okay, so when you are saying I am trying to do dialysis for management of sepsis, you are not talking diffusive clearance, right? So it is always the H, not the D, right? So the H is very important here. And since when? 2000, Claudio Ranco came out with his excellent paper where he said increase the doses of the replacement and you get better cytokine removal, and till 35 ml per hour, kg per hour, if you increase, you have an improvement in the survival. At 45, you don't. I am aware that there's a lot of literature that came out later contesting this, but what did it bring out to all of you? Was this the only change that was made where you said, okay, I'm going to prescribe a dose of CRRT for organ support for the kidney? Was it all that we learned from this seminal paper? Because dosing CRRT for organ support is what? We are talking control of acidosis, pH, acid-base control. We are speaking about volume control. We are talking about solute removal. That is what we say when we say organ support for the kidney. Hyperkalemia. So these are the 4 primary things that we talk about. But when you say dialysis for sepsis, is that all you're talking about? Why were the patients improving? Was it because they were delivered a higher dose of dialysis? Or was it something more? So that brings us towards, people trying to increase the doses of replacement to 60 and 120 without showing us enough benefit. So something is not working out, right? So this we'll not talk about today. Basically, this is what we learned. We learned about convective clearance of certain molecules, whatever the toxins they were, that helped us improve the mortality at that point in time. Once you believe in this, you always speak of pro-inflammatory and anti-inflammatory cytokines. You always have this in your mind. If I remove, will it be, it's not directed. I'm removing the good and the bad. What will I achieve? But then if you realize it's because the bad is much more than the good that your patient is dying. And that is why possibly this paper showed you that convective clearance will improve mortality in these patients. That's the hardest endpoint in our practice, right? So if what we are doing at 35 is not made better when you go to 45 or 60, so maybe that is not the only way to treat this. We have agreed on one thing, that there is an inflammatory cascade that is leading to mortality. There is, in COVID we had this cytokine storm. The word became like a common thing for all the lay public. And that is what we are talking about. We are talking about cytokine storms. And we are talking about pro-inflammatory mediators being so much in excess that they are not helpful. They were supposed to be helpful, but today they are not helpful for that particular patient. And what can you do to remove them? And that's where the adsorptive filters kick in. So this is known to all of you in the audience. You have 2 basic enemies. You have the LPS from most of the lipopolysaccharide antigens, and you have the immunity. Is immunity good or bad? Of course it's good. It was developed by nature to help us survive, right? But if it works like this, it is killing the same patient that it was meant to help. So organ dysfunction, different organs, different presentations. But what was central to all this? That excess immune response is bad. And that is a central theme when you speak of adsorptive filters in sepsis. So this is the concept, and that is why nephrologist in treatment of septic shock is the new reality. And we'll talk about more as to what we are doing and why we are saying that this is maybe the way to go in the future. So endotoxin, is it measurable? Can you measure endotoxin? Yes, it is. In 30 minutes or even less than that, you can get an LPS level analyzed in a lab and delivered to you. So you can have an endotoxic assay. Can you measure cytokines? Of course, yes. In COVID, everybody was measuring IL-6 levels. So there are some cytokines, pro and anti, that can be measured. So now you have indices available to you for measurement, which have a direct correlation with mortality. So at this point, if somebody was to tell you, do you believe this LPS is bad, this endotoxemia is bad? Yes. I think that answer is equivocal. Not equivocal, it is unequivocal. It's the whole audience saying, yes, it is bad, right? So should we remove it? Because it is the antigen of the cell wall of the bacteria. By killing the bacteria, you will require a lot of time for this antigen production to stop. So whatever is circulating in the circulation, if it comes down, comes out, will it be helpful? So this is the cytokine pathway. There are so many names to all these cytokines that it becomes confusing for us practitioners in the, you and me here, to understand what is good and what is bad. We understand there are pro and there are anti, and there are some which are good at some times but bad at others. So really speaking, it is all about timing. It is not about a particular marker, like not about endotoxin. Yes, it is bad, but about cytokines. So if you can do something like this, where you have all these extra cytokines which are not helping you right now, if you can remove them with whatever cutoff, and you can show an improvement to the patient outcome, I'm sure all of us will welcome it. So there are different filters available now. Some of them are available in our country at the moment, and I'll go through a few of them just for the sake of. So today I'm not trying to tell you that this is the standard of care as of today. What I'm trying to tell you is that this, I believe, will be the standard of care in the future. Maybe not this, maybe better therapies will come out, but adsorption as a technique. See, remember, us nephrologists, we spoke of only three things: diffusion, convection, and osmosis. Today, I think we should talk of adsorption, because we are the people who have this kind of access to blood volumes. When you do a regular dialysis, your blood flow is 500 ml per minute, 30 liters an hour, 120 liters in 4 hours. Who else gets to handle 120 liters of blood in 4 hours? If you can purify that blood and give it back to the patient, and you can show an improvement in the outcome, that is the future of critical care nephrology. So toremexin, it's an extracorporeal hemoperfusion cartridge, which is basically an adsorption for the LPS in the blood. So particularly gram-negative sepsis, septic shock, endotoxemia. What is it? It is a polystyrene-based fiber where the polymyxin B is bound to it covalently and it is immobilized. So can you achieve the same by giving supranormal therapeutic doses of polymyxin B to the patient? You can't. Because here the polymyxin is holding on to the endotoxin and keeping it out of the circulation. A bound giving supranormal A, you will risk the side effects of polymyxin, and also it will take longer to work compared to this particular technique. So adsorptive capacity is huge. In a particular filter, the adsorptive capacity would be something like 64,000 nanograms. If you look at the levels of the LPS that is enough to kill us, it's in hundreds or thousands maximum. 64,000 is huge. Cytosorb, I think this is familiar. I'm sure most of you must have used this during the COVID pandemic with the cytokine storms and our not so well understood understanding of this concept, right? So again, a polystyrene based, okay, that's automatic. Okay, it has a huge surface area. Basically, what we need to understand is cytosorb is non-specific, like most of the filters available today. Okay. However, because of its the pore size and the adsorption coefficient being pretty good, it has shown possibly the best data as of today, positive data, is with cytosorb. So this is the setup. You just have one more cartridge in addition to your dialysis filter, and you can run it with almost everything, not just your CRRT machines. They can run it with the ECMO, you can run it with the heart-lung machine. The cardiac surgeons who are doing a heart transplant actually put a cytosorb in series. Again, like you mentioned, that it is not the standard of care as of today, because nobody has shown without a bias that it has a survival advantage. But what I'm saying is, if a lot of us are starting to believe in it, maybe we are seeing something that is making us do it, correct? Oxyres, another filter. The advantage with Oxyres is that you don't need another cartridge. It works both as a dialyzer as well as cytokine adsorption. So it's easier, less expensive compared to cytosorb. But again, the data is much better with cytosorb, like I said. You can use an Oxyres filter with everything. You can use it with your SLED machine or with your CRRT machine. This is a polycarbonate based filter. So if at all, I have not seen any allergic reactions actually to any of these filters that we have used, so not much to dwell on it. Hemofil is basically from Japan. It's a PMMA based cartridge. Again, it was very good, but again, like anything Japanese that we have seen till date, somehow it doesn't get enough evidence to go through the FDAs of the West and gain the standard of care. Hemofil is like Oxyres to most of us, where it will be enough, it does both, it does your dialysis as well as it will help you with the cytokine. So this is adsorption versus absorption for the naive, if at all. So when you are speaking adsorption, you are not always talking of adsorption with dialysis. And that is what I was trying to say at the outset, that CFPS was some another day, that when we are talking about role of nephrologist in sepsis, I wish to delink it from AKI. It is not about organ support. We are talking doing dialysis for management of sepsis, like how you are giving antibiotics or you are giving organ support for the lungs. We are giving this as an additional therapy to improve the outcomes of sepsis. So is it for all sepsis? Definitely not. It's only for those where the mortality is expected to be very high. You're going to lose 2 out of 3 patients. Yes, please try this early. So as I was telling you, look at the data. So used for sepsis treatment in the European Union, all of them. All of those in the, all the filters have been used at some point. Specific approval as a cytokine filter is only for cytosorb in the EU. In a randomized controlled trial, broad cytokine removal proven only by cytosorb and Septex, not even for your any other filters, not even for PMMA. RCT data showing improvement in mortality in sepsis only for 2, cytosorb and the torimixin. Independent, platform independent, a lot of them. Single circuit setup for cytosorb and for torimixin. Others would require necessarily the dialysis machine to go with it. Binding capacity might not be easy to get. But basically understand that you can use a polymyxin or a cytosorb in absence of dialysis indications. So what is hemoperfusion basically? We are speaking about blood going through a column containing some adsorbent particles. Like you know how you used to speak of charcoal hemoadsorption, right? For poisonings, barbiturate. We are still doing it, right? So something like that. You have an adsorption. You just have to choose what you want to adsorb from the blood. So these therapies are expanding. I'll speak about bilirubin, but even for young neonatal connectors, there are therapies now where a nephrologist can come in without any presence of renal failure and help remove that particular offending agent from the bloodstream just by doing adsorption. So extracorporeal treatments, hemoperfusion is now one of the treatments that a nephrologist should be ready to provide as we do for others. How you do a scuff for heart failure in absence of renal failure? So non-dialytic indications of dialysis is what we are talking as a broad subject when we speak sepsis and infection. So extracorporeal therapies, hemoperfusion, the important thing to understand is here you are talking about removing, it's not specific, okay? So when you are speaking about binding agents, as of now what we lack is specificity. So that is where the hurdle is, and that is why I think the science as it stands today is not able to provide hard evidence to make this the standard of care. So once that hurdle is crossed, this will become the standard of care, is what I feel. So like I was speaking about dialysis for the non-renal indications, you have liver support, Mars, Prometheus I have never used. So this was the cartridge I was talking about, the BS330, right? I'm sure some of you in the audience may have tried it, right? So single use, but basically you see the bilirubin levels dropping by like 70% from where you started. And we believe that bilirubin is a direct pathogen when it comes to whether it is renal failure or brain damage in connectors, correct? So removing it. In organ support, yes, we can use it in patients with ACLF, provided that other therapies to treat the root cause are going simultaneously at the same time. We had a patient with ACLF with a bilirubin of 50, and while they were doing plasma exchanges to bring it down, they wanted an urgent relief from the liver transplant team to bridge over to transplant. And we had used it with excellent results. Results only from number perspective, okay? Then results from the patient perspective are not yet standardized or proven. So that is why, again, whatever I am saying, please understand that what I am saying is that the evidence as it stands today, these are not the standard of care, but because they are showing good outcomes in clinical practice as well as in data as it evolves, they may hopefully become the standard of care. So this we have spoken about. Most was touched upon a lot before. So this was a patient we had. I am just showing you a last snippet to show that how different therapies can be combined. So this was a patient with community-acquired pneumonia, came in with sepsis, MORS, AKI. So this patient was on simultaneous use of all these things. Standard supportive care, online hemodiafiltration, lung protective ventilations, ECOR, and cytosob. So basically, this is it. So different extracorporeal support devices available that were used included hemoperfusion cartridges, plasma apheresis, liver dialysis with albumin, ECMO was ongoing, and so was ECOR. And this patient managed to survive and leave the ICU after 7 days. So these are patients that bring hope to us that maybe the new therapies that are, basically you would have written off this patient who is needing so many supports. You would have said, okay, there's no point in doing anything. But perseverance and a patient whom I never thought would survive actually made it. So anticoagulation has already been dealt with. Antibiotics has been dealt with already. So this is something work that we did, this was about some data about cytosob to the audience as to if you're looking for what are the articles that are positive. When I said that we have positive trials about cytosob in sepsis and septic shock, this is some data that showed prospective that the cytosob therapy by hemoadsorption is a new technology in addressing these inflammatory conditions. Oxyris has data again with endotoxin absorption. There's a lot of data. If you look up, you'll see a lot of data with all the cartridges that I have mentioned to you. Okay. I'm not going to spend time on this. So this was something that we did a few studies with our, so we have published some articles in Indian Journal of Critical Medicine, in American Journal of Critical Care. There's an article hopefully coming up in Lancet soon. So our own data with adsorption filters in different settings. And this is something that we are doing right now at Reliance Foundation Hospital, Mumbai. So we are trying to say, we are having a refractory septic shock protocol where we are saying that we will be using cytosob because that is the only one with positive data as of now. And we are trying to measure the cytokines that are available to us. Thankfully, Reliance Life Sciences has a nice setup and they're able to do some fancy work which we only thought would be available in some labs which are not in clinical domain yet. And we should be, if this comes out as a positive trial, it will be something very nice for all of us to take home that we'll have measurable indices. See, what is lacking today is measurable indices. How do I know I'm not overusing these therapies? How do I know which are the right patients to choose and where I should go in with this? So just some time back we were speaking about a dengue patient whom once they have lactate more than a certain number, mortality is 100%, correct? Only last night I think we were discussing that patient. And that's the thing, that when is it irreversible? And at what point do you want to say, okay, I should use some of these techniques which are available to me now before it is too late? So those are unanswered questions even today. And that is why we are trying to learn markers. And hopefully these markers will show us the way as to which technologies and at what time to intervene. These are two crucial things for us to learn. Which patients to intervene in, what time to intervene, and which therapies to choose. So newer therapies are helping, further validation is needed, But this statement is there. Critical care nephrology as a new subspecialty of nephrology has tremendous scope in management of these patients, and we as nephrologists will continue to give care in a better way as time goes for management of sepsis, septic shock and ICU patients. Thank you so much for the invitation and the patient hearing.
Thank you, sir, for the nice review. This is a physiological way of treating the pathophysiology of sepsis. That is very well taken and understood by everybody. But still, with whatever data and experience of yours, can you tell us the subset of patients in whom we should push for using these filters? And how long to use, and what are the factors when we should cut down and not go further?
Exactly the question that I was trying to say in the last part, that it is very difficult because right now you don't have measurable markers or indices. You don't have IL-6 levels available to you. You don't have LPS levels available to you. And this is in the golden hour that you need these levels. Today I have the advantage that I have LPS level available to me in less than 30 minutes when I need to use.
So for us in peripheries, in two-tier cities, we do not have access to these levels, nor it is affordable for our patients.
Actually, it's
still,
not
what
expensive.
would be the clinical markers that we should consider in our patients to push them for, because it is a costly treatment?
So I think the only thing that I would say without availability of markers for today is maybe the use of polymyxin in proven gram-negative sepsis. Other than that, cytosorb or oxyrase remains experimental, and standing on a podium, dealing with not a particular patient but a nephrology audience, to say that we should use it indiscriminately is definitely not on. The only place where you could use it with certain degree of surety is suppose you have a patient in your ICU on triple inotopes not responding, gram-negative sepsis, please use. Because that is the only clinical indication where you may be able to justify the use of an expensive therapy. But unless you have access to markers, and that too in a quick turnaround time, using these filters on a routine basis will not be advocated.
What is the average number of sessions that you have done, the duration, and also how would you reuse the filter, if at all?
So, see, the guidelines with cytosorb would say that after 6 or 8 hours you need to change it necessarily, right? With polymyxin, again 12 to 24 hours depending on which way you are leaning is where you need to change the filter. These filters on an average are going to set you by a lakh of rupees at least, depending on whichever way you negotiate with the companies and provide whatever discounts to the patient. That's an average cost that will come to you. Oxyrase that way is less expensive. If your patient has renal failure and septic shock, it's around 40-50,000. You can use it for up to 48 hours. About reuse or whether you would like to continue using, I mean, unless you are really monitoring something, what are you treating? I mean, maybe the first time you use a cytosorb, fine, you had a cytokine storm, your patient, you were in that window, you thought, I need to buy at least 12-24 hours for my patient, you used it. But beyond that, to continue using, unless you have measurable markers, so what is limiting the use of these therapies today is quantifiable, measurable markers which are available to us in a quick turnaround time. So that, but if we are going to say that, we are going to use this, like when IL-6 started in COVID, we never measured IL-6 before. But the IL-6 reports were available to us by the end of the day in all patients where we asked for it. So if we ask for something, the labs are ready to provide the backup. But if we are going to use it regularly and as a standard of care, they'll become available. So that's what I was trying to tell you, that this particular study that I'm doing now, it's an RCT that we have done. It's not a proper RCT, it's a 1:1 randomization for every patient who is walking into the hospital.
So as I have understood, a single session is to be done, and if we have reached an endpoint of that particular marker, then we probably don't need to use it again. So
It
the
is.
reuse is out of question.
In very simple words, it is something to buy us time till our therapies for sepsis work.
And amongst the preference of using cytokine removing filter versus an LPS or an endotoxin removing filter, what should be the preferred choice and the timings?
My bias is in gram-negative proven sepsis, because that is what is actually the worst thing in our ICUs as of now. Towards the toremexin is, I have a bias. That being said, the best quantifiable evidence as of now remains with cytosorb.
Let's open the house to the questions. Open questions to the house.
What about the idea of using serum lactate as a surrogate marker of improvement in sepsis, or when you use these kinds of technologies?
Definitely. I mean, that is showing the patient showing the response.
Yeah.
And not just markers which are, meaningless, but usually improvement in lactate comes a little later as compared to the markers that we are able to measure.
So in the experience that you have of these use, what is your mental image of the success stories versus the failures? I'm not asking for a very specific scientific analysis, but in which patients you found that the use of this technology contributed at least to patient survival?
So cytosorb in rhabdomyolysis, a definite yes. Toremexin in gram-negative sepsis, if started in the first 3 hours, good results. Cytosorb, when the trigger can be taken away, good. Other than that, it remains all experimental.
Thank you, sir, for such an informative session. Just 1 or 2 points. Since I'm an intensivist, we've been using these filters in last 1 or 2 years. There has been increased use. Now, whatever I'm saying now is only from my experience, not from studies. We have a lot of data, everything, but everybody has to extrapolate the data according to the kind of patients that you are dealing with, the pathophysiology of the disease, and definitely. So one thing which I have seen is, to answer your question, sir, that one has to, the patient selection for all these therapies is very important, as it is important for CRRT, for ECMO, ECOR. Similarly, for purification systems, the selection of patient has to be very important. First thing is, you have to see the rapidity of the deterioration. The more rapid the deterioration is, when the patient comes to you, the less chance of success. That is what we have seen. Like dengue shock syndrome, when they come and within 1 or 2 hours, the lactate rapidly rises, they get intubated, hemodynamic instability, nothing helps, nothing. So you have to actually have that expertise to see. Yes, definitely you may offer, because it is what people are doing these days, but from our personal experience, at that point of time, nothing works. Another thing is lactate clearance. Yes, I agree with you, is one of the things which actually guides us a lot. It is a poor man's test, if I may say so. IL-6 we are sending for all the patients. We are getting good results post adsorption therapy also. But lactate, after, say, if we are giving a run of 8 hours, if my lactate is going down and my hemodynamics are improving, without any further fall in urine output, or the urine starts recovering, I know it is working for the patient. He may take time on the ventilator, he may take time on the sepsis, but these things, we know we are in the right direction. These filters are very expensive. I don't think second or third filter helps a lot in those patients. If the first filter is not helping, second or third filter may not be that beneficial. But yes, it is a case-to-case decision which has to be made. Another thing is the hemophile. Now, between these three filters, there is a difference since I am working in a setup where my patients are usually from rural background. We get a lot of poisonings, we get a lot of sepsis who come late to the hospital and they already have drained their finances. There are three options for them. One, cytosorb, which is around 90,000. With CRRT, again, the cost goes up. You can add 25,000 to that. Hemophil is 35,000. It can be used with SLED. It can be used with, you don't need an extra filter with hemophil also. Oxaris, the disadvantage with Oxaris is it is 70,000, but it can be only used with Prismaflex, with Baxter machine. If you have Fresenius or any other machine, or if you are not planning a CRRT, you cannot use Oxaris. You have to give the patient CRRT with Oxaris. So these are few things again which decide what kind of filter you may use. With cytosorb, you need an extra filter, but with cytosorb, you don't need a dialyzer. I'm sorry, I said filter. With Oxaris, you don't need an extra filter. That is the only advantage between the two. But yes, definitely the financial aspect of it and the rapidity of deterioration is one of the things.
I think I agree with everything you said, except the rapidity of deterioration. Because I think it's all about, these are the actual patients who need the therapy. It's just that they are coming so late to you that that whole golden 1 hour, 3 hours, 6 hours, everything has been lost.
Gone. Yeah.
So actually these are the real patients who are going to benefit from use of these filters. So basically to summarize, hemophil and Oxaris in conjunction with dialysis, because they have a dialyzer inbuilt, cytosorb and the toremixin independent of dialysis can be used. And if they are used in patients on dialysis, you have two filters in parallel going with each other.
So there was a concept of peak concentration hypothesis when it is in immune-mediated sepsis damage. So we are measuring only IL-6, which is pro-inflammatory. But that is the initial part, which is hyperinflammation. Once it subsides, there is a phenomenon of immune paralysis, where the immunosuppressants they take over and the infection disseminates. So your study was very interesting, sir. But my question is, are you measuring the IL-6 to IL-10 ratio, or only IL-6 is measured?
No. So in the RCT that we are planning or starting to do, we still have to get that ethics clearance. They are still discussing that. But we are planning to measure IL-2, 6, 10, LPS.
Because we...
And of course the CRP, PCTs, etc. with it.
Because that was the message what we got in the Abdominix and other trials which were for endotoxin trials. We didn't measure the immunoparalytic agents, we just measure the pro-inflammatory agents.
So unless, see, immunology is a branch which we still don't understand so well, and it is still in evolution, I feel.
Yes.
Because this whole concepts will change in our own lifetime as things go forward. But as they stand today, these are what are measurable with some, and you have a marker and an outcome. So this is available right now with the 4 things that I said.
Right.
So 2, 6, 10 and LPS. So these are the ones that we should measure.
Because that may be the reason why the sepsis 3 definitions change now.
Yeah, true. Very true.
So we are moving away from a blanket definition of sepsis to the patient's response to the infections.
Very true.
Thank you, sir.
Thank you. Thank you. Yes, sir.
This is a clarification I request for the last statement.
Yeah.
This 6 hours, 3 hours or 1 hour and our response to the sepsis accordingly, does it start with the time that the person develops sepsis or the time that the person reports to your ICU? What is the time? What is the framework? So I think the framework is how quickly as healthcare providers we respond once the fellow reports to your hospital.
Actually,
and then
no,
if we
sir,
respond promptly, then possibly survivals will differ.
Definitely we will shorten the window if the more prompt the response. But like in any code blue or code stroke, it is the time of the event to the reporting. So this particular time in the ICU setting that we say 1 hour bundle is the first hour of our response.
Our response, that's
but
it.
That being said, what is really important to the patient's outcome is a point of the shock becoming irreversible to the point for where we intervene. So that duration is critical. And
But
that is not exactly measurable.
Our control. That is
yeah, it is
beyond
that not exactly measurable.
If there are no further questions, we close the session. Thank you, sir, for the wonderful deliberation.
Thank you so much.
Thank you, sir, for the elaborate talk. Now I request the respected chairpersons to present a memento to Dr. Deshpande, sir. Further, I request Dr. Kundan Vadai, sir, to present a token of appreciation to the chairpersons. Thank you, chairpersons, and thank you, Dr. Kundan, sir. Thank you all. It was a great learning experience for all of us. We would like to express our gratefulness to all the esteemed speakers, chairpersons, and delegates who have graced the occasion. Now I would like to invite our Secretary, Dr. Pranav Kumar Jha, sir, to place the formal vote of thanks.
A very good afternoon to all of you, and on behalf of the Nephrology Society, I would like to thank our eminent speakers, Dr. Rishi Deshpande sir, Dr. Ajay Kher, Dr. Vinita Goel, and Dr. Girish Kumtekar for accepting our invitation and enlightening us on various aspects of CRRT and adsorptive therapies, etc. And I would also like to thank Dr. Surishi Prande, Dr. Afzal Sheikh, Dr. Anand Chelappan, and Dr. Girish Kumtekar, and technical staff of Resilience team, who will be conducting the workshops soon after the lunch. And my sincere thanks to all the respected senior members and colleagues of Nephrology Society for their support and help. Special thanks to Fresenius team for wholehearted support for this program. And I would be failing in my duty if I don't thank Himanshu and his team from Prism Events for coordinating and promoting this scientific activity. Last but not the least, thanks to all the delegates for gracing the occasion and attending the scientific session. Thank you very much. Please join us for the lunch. Thank you. Hope all of us had the lunch. So we are moving to our workshop now, and we will have a single group only. It's very informal. You can sit, you can stand, and you can see the demonstration. Anand will be doing the machine circuit demonstration first, which will be followed by the troubleshooting alarms by Dr. Girish. And after that, ECMO connectology by Dr. Afzal Sheikh, who is here now. And finally, we'll have a look at the membranes and fluids. So over to Anand.
Thank you, sir. So very good afternoon to all. So I think if you can be seated also, I think it should be fine. So thanks to the organizers for having given us the opportunity to be here. So CRRT, so as far as my perception is concerned, and I was just sharing my thoughts with others, I've always believed it's like, is it complex renal replacement therapy or is it costly or cumbersome? But then how the technology has evolved over the past several years, it now looks to be a cool renal replacement therapy. That's what I personally feel. So the technology has grossly evolved since its inception in 1977, Peter Kramer. So what we have now is possibly advanced technologies which are giving us quite a lot of things to monitor as far as the therapy is concerned. So this brief workshop would be to highlight on all those technical aspects. A lot of scientific aspects has been discussed in the morning by the experts very lucidly. So touching upon the important points of it, and as far as the technical we'll be seeing now. So the machine and the circuit is what I'd be discussing in very brief. So when we talk about machine, so we have one of the machines here, which is the Fresenius Multifiltrate Pro machine. And of course, the other green boy that many of us have seen is the PrismaFlex. So if you have to understand these machines, what I believe is there are grossly 5 parts. So the monitor is one that we need to be aware of. And there are scales, like we have 2 scales here and 2 scales on the bottom. Now, the scales enable us to measure the volumes of the fluids, and they're very accurate in calculating the effluent dose. That's how we calculate the dose in CRRT. So the monitor, the scales, then you have the pumps and the pressure pods, then you have the effluent lines and the circuits. So this is grossly with all both the machines, this is similar, but they have some differences with respect to the number of pumps and some minor differences between them. And the other important parts is the anticoagulation that we have along with this machine. So this machine gives us both the citrate and the heparin anticoagulation connectables and the parts. So we have the infusions for the citrate and the calcium. And if we want to go for the heparin infusion, the machine has an heparin infusion pump on the side. And apart from this, since we are doing a therapy which can also cause some amount of heat loss and this temperature loss, we need to warm the fluids or warm the blood lines. So heater or warmer is also an essential part of these machines. So when we see these machines, to summarize, we have the monitor, which is important, the scales, the pumps and the pressure pods, the dialysis circuits, the warmer, and the anticoagulation machinery, which is extremely important. Now coming to the warmer, very in brief, so Fresenius, it believes in heating the dialysate solutions. So on the side of the machine, we have 2 sleeves with which the effluent can be warmed. So this is the Fresenius technology. When it comes to Baxter's PrismaFlex, they believe in heating the blood lines which are returning with a sleeve. So that's how both of them differ, but I don't think there's any gross difference in evidence as far as which is superior over the other. So you have the warming system on this side. So this is grossly the parts of the machine. Now coming to the circuit per se, if we can just take out the circuit. So all these circuits, to understand it very simply, we can divide it into 4 parts. So the first part is the inflow or the access part, which is the arterial part. So it starts with the patient's catheter. So from there we start the arterial part. Can we open this? Is it possible? So things have been made very easy. So to begin with, in 1977, all of this were manual, and they had to use manual pressures to cause ultrafiltration. So now it comes as a preloaded set, which we just need to hang and attach it to the places. And the monitor is very informative in the sense that it gives us instructions as to how to install each of the parts of the circuit. So let's just briefly hang this, if that's possible. So in this circuit we have the arterial segment. So it's highlighted by the inflow segment is highlighted by the red color. So where does it start? It starts from the patient's catheter. So ideal sites of the catheter, just to highlight on the importance of the vascular axis, the preferred axis is usually the right internal jugular, followed by femoral and then the left internal jugular. A good vascular axis is extremely crucial because that also affects the longevity of the circuit. And the lesser the longevity, the more the downtime, the dose delivered to the patient is also less. So in the inflow segment, what we have is the arterial lines. So as we see here, so yeah, so this is the arterial line. So it just goes through this, and there's a blood pump here. So you have few pressure pods here. There's one here, and there's one after the pump. So the one before the pump, as you all know, it gets connected to the axis. So this gives us the access pressure. Now understanding these pressure pods is also important because the information that's going to be displayed in the board is all taken from this. And this is how we use all these information to modulate the therapy as well. So this gives us the access pressure. Just an important knowledge point, the access pressure is usually negative because it's sucking in the blood. But if this is connected to the ECMO circuit, like someone else had also asked, the pressures may be positive. So then we have the access pressure. Then once this is locked, it automatically locks itself. This is not loaded here. Then you have the pre-filter pressure. So after that we have the filter, which is, do we have a filter? Yeah. So we have the filter here which is loaded. So another advantage of this system that they have is a filter which can be changed separately, whereas that of the others brand is usually comes as a part of the circuit itself. So the entire circuit has to be changed. So there's some modifications, but grossly both of them have similar circuitry. So we have the filter. Just a few points about these filters. These filters are usually very high flux filters, unlike the conventional filters that we use in hemodialysis, which range between low, middle and high flux. So these filters are made up of biocompatible material, AN69, polyether sulfone or polysulfone. So we connect the arterial end to this, and then we have the venous limb. So before the filter, we have the pre-filter pressure. So one of the important pressure measurements is the pre-filter pressure, and then we have the venous outflow and the outflow pressure. So the difference or the pressure drop occurs between the two can tell us some idea about clotting or clogging of the membranes. These are porous membranes, so they have more chances of clogging and as well as clotting. So importance of these pressures is not a single value, but a trend of it has to be seen in the machine. And that will give us an idea of whether the filter is clotting or not. Like a progressive increase in the transmembrane pressure would give us an idea that possibly the filter is going to get clotted over time, or sudden increase may indicate either a kink in the tubing or a clot in the circuit or in the dialyzer. So we have the pre-filter pressure, pressure pod here, and then we have the filter. So the first segment is the inflow or the arterial segment, and these are the various parts of it. So they also have certain infusion lines as we see. So this can be used for infusion of fluids, and there's also an heparin infusion line along with the segment. Inflow of the arterial segment, we have the heparin infusion line, and the heparin infusion pump is on the side. So the usual dose we have already discussed is usually bolus followed by an infusion. Roughly around 10 to 15 is a bolus, and 5 to 10 units per kg per hour is usually the continuous infusion that we give. Now after this we have the blue lines, which are the
venous or the outflow lines. So in the venous or the outflow segment, we have the drip chamber, then we have an optical optical sensor, and then we have the venous line clamp. So these are the various parts, and we can also infuse the post-pump replacement fluid, post-filter replacement fluid at this point. So if there's any air interface, so this can be automatically clamped. So this also has a venous pressure sensor. So the pressure difference between the two would help us identify any changes in the clotting of the filter per se. So that's about the venous or the outflow arm. So three parts we have already seen is one is the inflow or the arterial, then we have the filter, and then we have the venous or the outflow segment. Now these are all the blood segments. So there is a non-blood segment that we can call is the fourth part of it, which is the effluent part. So that will be connected to the filter. So it has a pump of itself. The effluent has a pump. So that's indicated by the yellow color here. So that will be connected to the dialyzer. So the effluent which comes out of the dialyzer will be pumped out of this by this pump, and will go into the effluent bag, which is usually hung on the scales below. So these scales are capable of handling around 10 to 20 kgs of effluent. So that differs between the machines. Baxter has a 5 kg effluent bag capacity. So this also has on the way blood leak detector and also an effluent pressure measurement. Now this effluent pressure, the pre-filter pressure, and also the venous pressure, all these are combined together used to calculate the transmembrane pressure. So changes in trends of these will be reflected on the monitor, which gives all these information, and it aids us identify changes in the membrane and the life of the membrane. So these are the four parts of the circuit. So the inflow, the arterial segment, then the filter, then we have the venous or the outflow, and then we have the effluent part. So there's some more pumps which are left out. So this is the dialysate. So among the non-blood components, we have the dialysate and the replacement pumps. So we have these two scales which are stationed on the top. This machine has a capability of 12 kgs on either side. So yes. So they will be fluctuating. Yeah. Yes. No. Having said that, the range of transmembrane pressures which are tolerated by the filters are different for, if I'm not wrong, they're different for each of the filters, which is also mentioned by the maximum capacity of the filters is mentioned by the manufacturer for each of the filters per se.
Because in conventional, we do get up to generally more than 100, but in CRRT machines, it is generally below 100. And the trends when they start going up, I want to understand what is the point where we should start worrying about the filter.
So usually I think it's beyond 150 that we usually have a concern when it comes to CRRT. So the ranges to begin with, it's usually in the range of 50 to 100. So when the pressures serially go up and the effluent pressure also starts becoming more negative, then it means the filter is possibly going in for a clotting in the future. So the trends have to be analyzed and it has to be acted upon. If I'm not wrong, sir, can...
TMP is different for different filters.
They give it in the...
if we talk of three filters, one is low flux, which is F6, F7, we use. Medium flux, we say Theranovas. High flux, we say Theralite, plasma filters. And then we talk about filters which are using double filters in plasmapheresis. The TMP starts dropping as the pore size increases. So it won't be uniform for all filters. So these are CRRT filters. Their TMP should not go beyond 250. So our target is to keep it below 150. If it starts going 150 and despite doing all the maneuvers, it is not coming down, we presume the filter is getting clotted within the span of 6 hours.
Yeah. And each of these filters, they have the maximum TMP tolerated, which is mentioned in them. Like it's mentioned 600 here, but then as sir alluded to, it's 150, 200. By that time, we see most of the filters get clotted. But when we begin the therapy, it's usually between 50 to 100 that we see. So coming to the dialysate and the replacement solutions. So a whole variety of replacement solutions are available these days. So with varying concentrations, and with different brands the compositions are different. So we face a lot of electrolyte disturbances, so as per that various modulations have been achieved. So near isotonic, the basic principle is to have it near isotonic to plasma. So these are the scales on which the replacement solutions are to be kept. So they open on the back and they are connected to the pump which pumps in the dialysate into the circuit. And the amount of dialysate to be given depends upon the modality. If you're using a CVHD and CVHDF, these parameters have to be set in the machine per se. And then we have the facility for giving replacement fluids. If we are thinking about CVHDF, so that can be given pre and post as a replacement. Now coming to the anticoagulation machinery here, so this machine has the set of pumps for the regional citrate anticoagulation, so a citrate pump, and it also has the calcium infusion pump. So citrate, as we had discussed in the anticoagulation seminar, it can be a part of an isotonic solution like Baxter does it, or in the Fresenius it's usually a hypertonic citrate solution that can be separately infused through the citrate pump. And the citrate pump also has a drip chamber here, and the calcium pump has an accompanying drip chamber here. So the citrate is usually infused as close to the catheter as possible in the arterial line, and the calcium is on the outflow segment. Now these are the various parts of the circuit. So the inflow or the arterial, then we have the filter, then we have the outflow or the venous, then we have the non-blood compartments, which is the effluent, and we have the dialysate and the replacement pumps. And for the anticoagulation we have the citrate and calcium pumps. If we are using the heparin, we have the heparin pump on the side. So in general, with CRRT, 30 to 60% of them even is done without any form of anticoagulation. But with anticoagulation, citrate appears to be much better than heparin, and for widely used indications. With all these machinery, it is possible to titrate the dose, and the machine is intelligent enough to modulate the dose as well, and makes life pretty easier. So these are the broad components of the circuit, the filter and the machine per se. And these machines come with a battery backup. I think this is around 15 minutes that it has. It has a battery on the back, and they have capacity to be connected to the computer machineries as well, to tap the data that is being generated as we are running the system. So I think that's about the machine and the circuit. Can talk about the troubleshooting of the alarms. Yeah, so these can be coupled with other filters as well. Like I think this machine has the facility to attach the adsorptive filters at this point with an extra handle to the circuit per se. And the circuit can also be connected to the ECMO circuit. There are various ways of connecting it, either as a separate or as a part of the ECMO circuit. Either before the oxygenator it can be connected. So in various ways it can be integrated with the ECMO circuit, which we will be subsequently seeing. You can just demonstrate the alarms.
So good afternoon. So basically, the circuit which we are going to demonstrate is there is a blood circuit and there is a non-blood circuit. The blood circuit volume is 116 ml. It is very important for these patients with like patient who has a less volume or the pediatric patient. The volume of blood circuit is 116 ml and followed by the dialyzer circuit, which dialyzer blood volume, which has a volume of 100 ml. 116 plus 100. So the similar way we have a, like for pediatric patient, we have a lesser volume of circuit available. Like the patient who has a 8 kg or 8 to 16 kg, we have a different circuit which has a lesser volume, let's say 74 ml, 18 plus 56 is the volume. And similarly, the patient who has more than 80 kg or above, we have a other circuit which has a higher volume because the volume of that particular patient is higher. And as sir has mentioned, there, using that circuit, we can integrate other adsorbent column like you have seen Cytosov, this Polyvexin B, then HL330, that filters can be easily plugged in that. And that machine can be integrated with the ECMO with different circuit configuration we can plug with. Moving towards the circuit priming, so हाथ से तो फिर so has already mentioned, we have a 4 component. This is the arterial line, filtrate or effluent line. This is for substitute, this is for dialysis. And this is our dialyzer. Dialyzer, like as I mentioned, as per the body weight of a patient, accordingly we decide. The dialyzer is, this is a hemo filter or ultra flux filter. It has a surface area of 1.4 meter square. It's a negatively charged membrane with hydrophobic nature. So not hydrophilic, unlike to other membranes. It's a hydrophobic membrane which repel the fluid from the membrane. So let me start the priming first. So this is the So this is not the low flux. It's basically ultra flux. It's more than the flux. Basically, the basic difference between this filter and any high flux or ordinary high flux filter is the pore size in this filter is bigger, but number of pores are lesser, because the agenda in CRRT is basically to remove the molecules in slow and gentle manner. So we never denote these filters in terms of flux, but though these are the high flux filter, even more than that. These are the ultra flux filter. And the membrane is polysulfone.
Filters are generally high flux filters.
We use high flux filters only.
There are two terminologies only. One is flux, second is cutoff. Flux determines the amount of ultrafiltration which is done per unit of transmembrane pressure. Low flux, medium flux, high flux. This is high flux. Cutoff determined by the molecule which can be removed. So low cutoff, medium cutoff, high cutoff. So high cutoff membranes are TheraLight, which can remove the light chains also, which are more than 36,000 Daltons. Medium cutoff are beta 2 microglobulin, which is 12,000 Daltons. Low cutoff, we take urea as a low cutoff, 500 Daltons. So this is high flux, medium cutoff. F6 is low flux, low cutoff. More than high cutoff is plasma, which will take the sieving coefficient for albumin for a plasma filter is 1. Whatever albumin you give it, takes it out. So cutoff is a different terminology, flux is a different terminology. This is high flux, medium cutoff.
So this has a capacity to remove 30,000 Dalton tones. So as rightly said by sir, it's a MCO dialyzer, we can say. It can have capacity to remove even myoglobulin and inulin also, which has a molecular weight more than 17,000 Dalton. So this is the, basically we just set it the circuit. We are doing CVV HDF pre-dilution. So I will demonstrate you, we'll set the circuit for CVV HDF pre-dilution, and followed by this we'll let you know how we can turn CVV HDF to pre-CVV HDF to post-CVV HDF, or CVV HDF to HD, CVV HD, or CVV HF. So using single circuit, we can switch and to the any kind of therapy which I mentioned. So this is the arterial line we plugged into the saline, you will see, and followed by this is the arterial pressure. Arterial pressure basically excess pressure. The pressure from the cannula we are taking blood, that has been measured by this. Here the arterial pressure is nothing with the patient. It is just to check the integrity of a arterial line, whether the blood is coming smoothly or not. If the more pressure is rising, that means the cannula is not placed well. Probably the tip is touching in the vessel. We have to take care of that circuit. Followed by that, this is the pre-filter pressure. If there is a problem in the circuit, or there is a membrane choking, or there is a high excess pressure, there will be a pre-filter pressure raise. From there, we will check it. Then this goes to the filter from the downside. Since we are doing priming, we kept the dialyzer on the opposite direction, because we are filling the dialyzer from down to upside. So blood is filling, the saline is filling from down to upside, and followed by, this is the return line. From there, it is coming. This is the post dilution port. We'll let you know what is post dilution and pre-dilution. And this is the excess pressure line, or return pressure line, or venous pressure line. Like if it's rising, that means there is some problem in the return pressure, or there is some obstruction, kinking, or clotting in the return pressure, we'll see. And this is the air trap. If there is any air, it comes in the circuit, extracarpal circuit, that can be diagnosed or that can be checked by the machine, and it will give air bubble detector alarm. And this clamp is responsible not to pass the blood into the patient body. It's a venous occlusion clamp. And followed by this, it will again return to the patient. Since we are doing hello. Yeah. So since we are doing priming, it's just collection bag. Once we'll connect the patient, it will directly go to the cannula on the venous return line. So machine is self-explanatory in terms of how to place the circuit. So let me start with the beginning. I just on the machine and put the machine on functional test. Once machine done their all test, functional test pass, we'll select the mode. We select CVV HDF pre-dilution. Once we select CVV as pre-dilution, whatever the mode we are selecting, with the same flow, the diagram of that particular therapy will develop. Let's say we have developed CVV HDF pre-dilution. This will demonstrate this is the venous line we have to place first. We have placed it, followed by next. Then arterial line will place it. It has been placed. Third step, we have to place filtrate line and dialyzer. It has been placed. And followed by the 2 bags on the back scale. It has been placed. And this is the dialysate and substitute line. It has been placed already. Once we, and this is heparin. 90% of CRRT patients are basically heparin free we used to keep. If we want to keep low heparin or with heparin, so this is the heparin line, we can place it via this heparin pump. Or dose of heparin you can set from there, we'll show you afterward. And this is the entire circuit with the color-coded graph. You can see this is the written blue one, this arterial the excess pressure, filtrate pressure, dialysate substitute, heparin and dialysate substitute. And color-coded you will see. Let me say OK. And once I say OK, machine will automatically take the things out. OK. So pre-filter pressure down not correctly. Just a second. Okay, since we forget to install this pre-filter pressure dome, so machine is giving alarm. Once I plug, confirm it. So since we have not put heparin line, it is, we will say no to the machine because we are not putting a heparin syringe on that, and we'll start priming. Now machine will do everything on its own. You don't require to unlike to conventional dialysis device where you have to many times remove the air and everything you have to do. There is no requirement in terms of increasing or decreasing the blood flow, turning the dialyzer from one way to other. This is not required. Machine will automatically, it is auto programmed, auto run, it will do. And here you will see the dose prescription. Okay, heater bag is not corrected. So, okay, done. Confirm it. And here the prescription you will see, probably sir will let us know how we'll set the prescription. This is the net ultrafiltration, rate of substitute, rate of dialysate, blood flow, heparin, how much bolus we want to give. This is for the temperature of dialysate and substitute both. And followed by the, in case during therapy, let's say you want to give some fluid challenges or the patient landed into hypertension, you want to give some fluid, and from here you can give bolus. So once we turn on the machine until we'll connect patient, it will take at least 20 minutes to prepare the entire circuit. Before that you cannot start it. It has on time, prefixed time, 20 minutes it will take. So mode we have selected is CVV HDF, and with heparin we are doing. Other than that, as in the beginning you have seen, we have a conventional CRRT mode, advanced mode like calcium citrate CVVHDF, calcium citrate CVVHF. Then therapeutic plasma exchange and pediatric CVVHD and CVVH can be done in that. So it is taking their own time, like in the meantime, we can discuss about the parameters of effluent probably, so if you can get us through. What is effluent and how?
Were already discussed in the morning sessions, so it depends a lot upon the hemodynamics of the patients as well and the effluent dose that we are targeting. So unlike in hemodialysis where we have KT/IV as a tool to monitor efficiency of dialysis, adequacy of dialysis, so here it goes with the effluent dose. So on the basis of that, we need to calculate the dialysate and the substitute and the replacement fluid. And in a usual adult, let's say it's the blood flows are kept around 150 to 200 ml per minute, at least not less than usually 100. So that's a usual blood flow, and depending upon the modality that we are choosing, whether it's CVVHD or HF or HDF, so that will determine the type of effluent and the dialysate that we are going to set in this machine. Like here they have set around 1000 ml per hour of substitute and dialysate of 1000 ml per hour. So the calculation, I think we had already discussed in the morning as to how it has to be divided between the dialysate and the replacement. So that's how the settings for that will come. And the ultrafiltration, of course, needs a periodic reassessment of these patients. But in what we routinely see in our ICU practice is that hourly monitoring of these patients becomes practically difficult. So cumulative balance is what we get to see. And like at the end of 6 to 8 hours, we have to kind of do a little bit of more of ultrafiltration and then catch up on the fluid accumulation that has happened. So if possible, a hourly monitoring and adjustment to be done. So that depends upon in which phase of sepsis or illness the patient is, whether the patient is in the resuscitation phase or in the stabilization phase, or you want to de-resuscitate the patient. So the fluid goals would depend upon that as well. So in somebody who's in the resuscitation phase, you would not be willing to do a lot of ultrafiltration. So if somebody who's in the stabilization phase, you just want to replace whatever is being given inside. For a de-resuscitation, you would aim for net ultrafiltration. So now coming to the calculation of net ultrafiltration, so it depends upon the modality. So if it's CVVHD, we need to take the ultrafiltration and also the dialysate flow. So together that has to be taken to calculate the net UF or the dialysis dose. And if it is in the CVVHDF, then it will also include the replacement fluid. So together that will contribute to the net effluent dose. That's something which we need to keep in mind. So based on the calculated dose, we need to divide it and divide it between the dialysate and the replacement in the case of a CVVHDF. Or if it's just CVVHD, then we need to keep it for the dialysate per se. And the UF we need to set. So here they have.
It is possible.
That can be done. Yeah,
it is possible. So maximum rate of dialysate and substitute, we can keep it, for substitute we can keep it 9.6 liter per hour, and minimum is 600 ml per hour. And in terms of dialysate, we can do 4.8 liter per hour. And in terms of ultrafiltration, 2.5 liter per hour maximum ultrafiltration you can keep, though practically not possible 2.5 liter because patients, such type of patient are so sick.
Having said that, what we follow in our unit is we usually divide the, if it's VRT, we usually follow CVHDF. So that's a common modality that we do. So we divide it between the dialysate and the replacement and give 50% pre and 50% post, and then reassess after 6 hours and then decide as to how any modulation has to be done. If the patient is on pressors, we usually don't keep do a net extra ultrafiltration initially for the first 5-6 hours, and then once the patient is stable, then we start adding ultrafiltration and then reassess the patient periodically. So you're telling something. So the cost of
the circuit.
Circuit comes to around 15 to 25,000 between both the brands, if we say. Like the Baxter Prismaflex kit comes around 15-16,000. So in the government sector, that's what we are getting.
Inclusive of the filter?
Inclusive of the filter. It has the filter in itself. I think their set is a little,
Less.
they should be able to say.
Yeah, so the entire cost, including filter, it will be 15,000 rupees, and that exclude the fluid. The fluid basically this, the 5-liter solution bag, that will cost you somewhere around 2,800 rupees. And let's say you are doing 1 liter per hour, each dialysate and substitute, you will require 10 bags a day. So this is how you can calculate it. 10 bags per day we required. And the life of circuit is 72 hours. This filter can last for 3 days, including circuit, in normal course, if it's not getting clogged. And this 1 bag cost is 2,800 rupees.
So roughly 50,000 day one it will come. And probably on subsequent days, just for the fluid, 30 to 40,000 it may come. The aims actually for the below poverty line, we are giving the fluids for free. Fluid for free. The kit is has to be brought. Yeah, kit has to be brought.
उसमें से रीसर्कुलेशन कनेक्टर निकाल दो उसमें HDF ट्यूबिंग में से.
Then as per the per kg body weight, do you have that 20 to 50 ml per kg or any?
That's the recommended effluent dose.
एक IV set
Usually the
IV
prescribed
set
dose should be higher because the delivered dose is usually lesser than the prescribed dose. So you keep it around 25 ml per kg. So that's the usual dose.
25
It depends upon the etiology of sepsis, and if you're having a hypercatabolic state where you need a higher flow, then you need to, of course it's not like a fixed thing. We do modulate depending upon the kind of injury which is causing the renal shutdown.
A patient who is hypercatabolic,
You may go a little higher up, is 35.
but at the same time he is hypotensive as well.
Yeah, so basically most of these patients are on multiple pressors. So the net ultrafiltration is something that we could control on, and depending upon after the stabilization, the ultrafiltration could be slowly added on. So because whatever we are giving, we are going to remove it. So the net effect on the hemodynamics should not be much, depending upon the volume per se that is being depicted.
Perfect. Thank you. आ गया. Sorry. So this is the machine has been now prepared. We have taken machine in treatment mode. So like as far as this parameter is concerned, we have set 10 ml per hour of ultrafiltration, 600 ml substitute, and that substitute is basically pre-dilution we have kept, and 600 ml is the rate of dialysate. So I am considering this patient has a less body weight, that is the reason 6 plus 6 plus 10, 1200 ml per hour, 1210 ml per hour rate of basically affluent we are giving through. And this is, since we are not giving heparin, we kept heparin off, and this is the balance. Balance is something like how much negative you are doing. How much negative ultrafiltration you are doing, that is there. Treatment time is 0-0. Once time increase, you will get like 1 hour, 2 hours. As I mentioned, the circuit life is 72 hours is normal course. These are the pressures or trending graph you will see, like what is the arterial pressure, venous pressure, or pre-filter pressure. If it's increasing or decreasing, you will see. Once it develop over a time, you will see the pattern of graph.
This is what we were talking about. This is the arterial pressure. Since we have not taken any patient, so it comes in the positive, but arterial pressure, since we are taking blood out from the body, it always kept in negative. And it should not go beyond negative 250 millimercury. So this is arterial pressure, and it is one of the most common alarm which used to come in CRRT is low axis pressure or low arterial pressure. So let me show you, let me demonstrate you. Let's say this is our patient. We have kept in recirculation, and this is the arterial line and this is the venous line. This is the axis line and this is the return line. So let me clamp it. You will see the arterial pressure, it will be more negative. And you will not rectify it if you are not removing this. If there is a problem in arterial axis, or your catheter is not placed well, or catheter is good, some vessel is touching on the tape, there will be a more negative pressure or more arterial pressure or axis pressure will come. So high axis pressure. Let me on it and it will come accordingly. You will see the arterial pressure will come out. So this is one more alarm, it used like very common in CRRT patient, because these patients are very low BP, vasocontraction will be there, and probably this may lead a problem. Then this is venous pressure or return pressure. Return pressure is belong to the return line. Let's say this is a patient and this is a return line. If something has happened in the return line, it can be kinking, it can be clamping by accident, or it can be clot in the venous chamber. It will lead a higher venous or higher axis pressure, higher return pressure. So let me show you how it comes. This is the venous pressure. Let me clamp it. I clamp it. You will see this will come up. The venous pressure, it is coming up. And high return pressure alarm. And once I release this or once I rectify it, this will, and you can see the spikes in the graph. The pressure is rising and spikes will be there. So this is the return pressure or the venous pressure. And third one is pre-filter pressure. So pre-filter pressure is measured from this dome. Anything has happened which leads a higher pressure before filter, it will reflect in the pre-filter pressure. It can be kink or clot in the venous header like this. I am kinking it. You will see venous pressure will come up because this is coming on the filter, and since it's not passing filter before pressure will increase. So this low TMP and pre-filter pressure will increase. So this is pre-filter pressure. Along with that, blood leak I cannot show you because we do not have blood. This is a blood leak sensor. If this is an affluent line, if let's say by accident or by something day 2 or day 3, our membrane get ruptured, there will be a RBC stains. RBC will come and it will detect by this, and you will get BLD alarm, blood leak detector alarm, via this. So this is called blood leak detector. Sometimes in acute liver failure where the patient who has a high bilirubin, sometimes we have seen because effluent comes in more yellowish in nature, more concentrated. That time also it used to check it. So we have a feature that time we can off the blood leak because it's a limitation. So there we can sense it. Then other than that blood alarms, there are some system related alarms. Because of something has happened on the scale, or someone has put weight or some curtain or some device is touching on the scale like this, which I have done, it will give error on scale 2. This is scale 2. So once I remove this will goes. Similarly for this and same with this. So okay, this is coming now. No blood is detected. So this is because of basically machine is designed on gravitometric scale. Whatever is removing from here, whatever removing from here, and whatever is removing from the blood in terms of ultrafiltration. A plus B plus C has to come here. If it's not coming, this will not work, or this will not, it will give alarm. So there is no hydraulic inside the machine. There is no water requirement, there is no drain requirement. It is whatever on the scale 1, scale 2 and ultrafiltration is removing, it has to be calculated over there. If it's not communicating well, we have to, like there is something or external pressure. It can be air also. So it is always advisable once we are running this machine, it is always advisable it has to be away from the AC duct, or direct ceiling fan should not be there, because some air pressure can even deviate the machine scales. So these scales are so sensitive in terms of that. Then in menus, we can have a care mode. In care mode, if we switch machine on the care mode, so the blood pressure will come down, the blood pump will come down with the 40 ml per minute, and all pressure range will be more wider. Care mode is basically, let's say you have a patient in day 1 or day 2, you have to give back care. They are sick patients. So during back care, you have to tilt the patient from one way to other, and giving back care, the catheter repositioning may require, or and that time machine will give lot of alarms. To prevent such situation, we can put a machine on care mode. It is a 6-minute program. During that time, machine will not give any alarm, and it will be a minimum blood flow, so that if there is any resistance in the cannula during positioning of patient, it can be managed. So this is a care mode. Once it's done, you can do continue, and this will remove. So this is care mode. Even let's say we started with CVV HDF pre-dilution, and started with CVV HDF pre-dilution in day 1. Day 2, you are assuming we do not require substitute now, because we want more gaseous correction, metabolic correction, and urea creatinine to be removed. So we do not require a substitute. So we can switch off the substitute. Now you will see this is the dialysate, this is substitute. Substitute pump will not work, only dialysate and 2 other pump will work. And machine will be CVV HD mode. And vice versa is also possible. Let's say in day 3, you will see we don't require dialysate. So we switch on the substitute and kept the dialysate off. So now this pump will stop, and all 3 pump will work, and machine will be on CVV HF mode. Only convective based therapy, middle and large molecule toxins we are removing. So like CVV HDF to CVV HF, CVV HF to CVV HDF, or CVV HF or CVV HDF. This we have kept CVV HDF post dilution. You want to switch to pre-dilution, which is more common in heparin free cases. So this is the switch to pre-dilution. We'll switch off, and from there we remove it. Sorry. And okay, so this is not the right way. We have to stop it, then we have to stop the pump, and we have to do it. So these ports are basically one-way thing. You can give something, you cannot take from that. This is pre-dilution port, this is post-dilution port. So you just stop the pump, and you can switch to pre-dilution and to the post-dilution. So this can be done from here. In CVV HDF, either pre or post you can do. In CVV HF, pre and post together you can manage. Pre and post together you can manage in CVV HF. Moving to the next, which is most common mistake user or SCP used to do. During, let's say, the bag strength is 10 kg. Let's say it is filled. they used to, like, they use directly, they remove it and they throw the, or they empty the bag. So it is to be done via program only. You'll see, you will go in the menus and there will be a, just a second. So it is communicating again, since we are playing much, so scale test is doing. So since the scale has a capacity to hold 12 kg of weight, which means at one go in single time, you can place 2 bag or 10-liter solution in one go, which means you don't require more frequency, you don't require more frequently bag need to be changed. It's like that only. Let's say you are keeping 1 liter dialysate or 1 liter substitute, 1 liter dialysate or 1 liter substitute, every 5 hours the bag need to be changed. It's like that. But if you kept 10-liter bag in one scale, for next 10 hours you don't require to change it. So it is communicating scale test, so that is the reason bag change is not coming. So I want to cost. So it is somewhere 18.5 plus GST. No. So it's just we required power plug, 16 ampere power plug, and you can start. Cost is negligible. So actually I am little dicey because we are not the commercial guys. They will let us know much. Okay, just देखो 3 4 में. Actually this is, there is a movement. Okay. There is a movement on the scale. You can see that there is a movement on scale. It is by which it is. Yes. So at a time. This is a 5-liter bag and this is a connector. Via this, there is no spike adapter we required. Again, tubings can directly plug. These are Leo lock connectors. You can break the con from there and you can place it. At a time, 2 bags on one scale you can place, so that lesser frequency of bag change you require. Because why we are so particular in this case, because once you are going to the bag change or once you are stopping the treatment, it is basically interrupting the treatment and it increases the downtime. So that is the reason. Sorry? Both. No, actually, CRRT, even we do not know how long it will take. Usually, CRRT is only benefited once it is running more than 24 hours. Even you will see by theoretically, by definition, it is like that only. Any extracorporeal device which is intended to replace a native kidney over and above period of time more than 24 hours, that is called CRRT, and that is the reason we recommend. It has to be run at least more than 24 hours. Then it is defined as a CRRT. So one scale is for dialysate, one is for the substitute. And so, okay, let me stop it. Let me go in the bag change. Let me show you how the bag look likes. So these are the 2 spikes. At one go, we can connect dialysate on this and substitute on this. 2 bag on each. Like this, we can do it. it's 10 kg each. So each scale has a capacity of 12 kg. Each scale. 10 plus 10, 20. And the maximum capacity is 24. Yes. So yeah, you can even see, okay, sorry. Even you can see how much fluid is remaining. 578 gram on scale this, 774 gram on scale 2. You will see like these scales are so sensitive, even I am putting this, it will sense 1 gram. So the scales are so sensitive in terms of weight, even they can 1 gram of weight it can sense. So once you want to change the bag or you want to empty the effluent, you have to go in the bag change, and this pop-up screen will come, and after doing your removal of the fluid and changing the bag, you have to go exit, and then it will again recommunicate and you can do it. Yes, that's what I was showing. So scale imbalance alarm only comes if I would place some additional weight like curtain or hand or something like that, then scale balancing error it will show. Or you have seen this bag, effluent bag has like it is touching with one blood tubing. That time you have seen there was a scale 3 and 4 has an error. So if any additional force which is working on the scales, bottom and up, then this error on scale will come. Or you are without commanding a machine or without knowing the machine that you are changing a bag, then it will come. Then it will come.
And the bags can be reutilized, like sometimes we are changing from 2K to 0K. And there is a partially utilized bag, and it can be reapplied, right?
Yes, you can do it. You have like there are two ways. One is the best measurement is like you want to use 0 to 2K of solution. So let the 0K of solution empty first, and then you can put another 2K of solution.
No.
If not,
what I'm asking is, we've switched from 0K to 2K.
Yes.
And then after a while, I want to go back to 0K. So that bag which was partially utilized,
it can be used. It can be used. Only thing
I
you
like
have
to change both the bags simultaneously.
It's up to you. Like you want potassium in dialysate or you want potassium in substitute. It's up to you. Right. Usually, no, nothing. Change volume. See, so this software work in a way, once we go in the bag change, this weight you can see. And if I am removing this and putting new bag, it start calculating again. It calibrate the entire circuit. So this works on that way. It will show you, see, the communication between scale 1 and 2, it is being checked.
So both the bags are dialysate bags and replacement bags at the same time?
It's up to you again. Let's say you are keeping more dialysate and less substitute. You want more diffusive clearance, less convective clearance. You are keeping 1.5 liter dialysate and 600 ml substitute. So the bag who has a more consumption will empty more.
Sir is asking whether you can utilize the same bag for dialysate as well as replacement. Right?
Is it okay?
So that is for a heparin CRRT. If you are doing a citrate CRRT, you have to use a calcium-free dialysate only, which is a Sika bag.
Yes.
Okay. Sika will be a mandatory dialysate. You can't use another calcium-containing dialysate. But for these are multi-big solutions. The multi-bigs you can use either as dialysate or replacement. So it's up to us to for a permutation combination. If you want 2K, so multi-bigs will come as 0, 2, 3, 4.
Yes.
It will come all sizes. So you want a replacement with 4, you put it as 4. You want less in dialysate, you put 0 Ks. So you want a more potassium clearance, you put both 0.
Yes.
Replacement plus dialysate. So the potassium will go out fast. But if you want to contain the potassium little slower, so you replace little potassium with say 2 and put the dialysate at 0. So the gradient will not fall quickly. So for heparin, any bag, okay. But for citrate, calcium free. Yes, yes. For Baxter, the dialysate bag is bifozil, which is calcium free. It contains magnesium though. So magnesium is also a divalent cation. So it also neutralizes some amount of citrate. But yes, yes, yes. But sometimes what we do, we put in a normal saline, 1 liter, and we add some magnesium to it and give it as a post-filter replacement, just to counter the hypomagnesemia. So it's a, but there is a hangers. This is not gravitational. There are some other mechanism. We have to weigh them. So it's weight sensitive for Baxter platform. These are all volumetric. These are all gravitational, right? These are gravitational. So the way we are measuring the fluid infused and the fluid taken out are different in two platforms, but they serve the purpose. So they are sensitive to an extent of 9 ml. The standard error is only 9 ml, beyond, not beyond that.
So this is what we are demonstrating. This is for heparin or without heparin circuit. So we have a similar circuit configuration for CCA, RC, renal citrate anticoagulation or calcium citrate anticoagulation. For that, the solution we are using, it is different from that. It carries, as sir has mentioned, 0 calcium, and potassium is, we have 2 variants, 0 and 2. And magnesium we already have is 0.7 milligram, and phosphate also. So this is for either with heparin or without heparin. But for CCA, we are following Berlin protocol. That Berlin, like in this interface, you will have one more value of calcium and citrate. So accordingly, you can, we have a 2 more bag. The solution bag for citrate named as a Cifoven, and for calcium is known as a CRRT. It's a calcium chloride. So Cifoven is the trisodium citrate 4%, and CRRT is a calcium chloride. So we can give. So this is, and it is as per the post-ionized calcium. This is the post-ionized, like from there we can take the sample of after dialyzer blood sample, how much calcium, and accordingly we can take a call how much calcium we want to go, or how much, let's say it is increasing by or decreasing by 0.5 milliequivalent, we will increase the dose of calcium, and vice versa also can be done. So this is a protocol, but it is a software driven, so beautifully designed. You can increase the dose of calcium or decrease the dose of calcium, and with respect of that, the rate of citrate is accordingly adjust. No, किसी भी machine में नहीं मैम. No one machine has made in a way it automatically like measure. We have to send test to the biochemist, then we'll be able to check it. Machine will not check anything. Yes. So other than that, we have this ECMO. So we can integrate this with the ECMO. There are 2-3 types of configuration. The best combination is before and after oxygenator. Like artery will connect before and venous. So this is the best probably he would able to see.
40,000 Daltons. Majorly inflammatory markers can be removed via convective or diffusion therapy. It's again a polysulfone membrane only, hydrophobic membrane, negatively charged, and using convection and diffusion you can remove up to 40,000 Dalton. Specially designed or specially recommended for the patient with a cytokines performance more or inflammatory markers removal you require.
So what we discussed is our mechanical troubleshooting. This is mechanical troubleshooting, the hardware part. There are some biochemical troubleshooting, acid-based troubleshooting, volumetric troubleshooting, and circuit life troubleshooting. So there are 4 troubleshooting. So we have to keep looking on the filtration fraction, and before the filter clots we have to intervene. We have to keep looking on the sodium. Before it drops to a precipitous level, we have to keep intervening. So these are like metabolic troubleshooting. So they have software built in it which tells us on these kind of things. So this is little more advanced version of it. So our life is little simpler now. We don't have to give calcium from outside. They have a slot for it. They have calculating the citrate dose based on our calcium infusion. The software calculates it. So the mechanical part has come down. The AI part is now taking over.
Hello everyone. This session is about ECMO with CRRT. I'll just brief you upon ECMO. What is ECMO? Rather, I would call it as ECLS rather than ECMO. It is extracorporeal life support. It can be incorporated for lung support as well as heart. So not only oxygenation, it can support circulation as well. So depending upon the need required, you can have it as VV ECMO or VA ECMO, veno-venous or veno-arterial. The first V denotes the access point. Access point is usually venous, most commonly femoral vein. The return point is either venous in case of respiratory support, so it is veno-venous, or in case of circulatory support, it is veno-arterial. The return line is either in the femoral vein or internal jugular vein in veno-venous, or it is in the arterial system in VA ECMO. Fine. So normal circuit, sorry, unfortunately we didn't get ECMO circuit. Somewhat it looks like this. This is the access point. This is starting from femoral vein. This is the line coming down. Here there is a centrifugal pump which is magnetically levitated. It is much different than this pump. Then this pump generates negative pressure. This pump is operated by this machine. How much RPM I can increase, that much blood flow it can generate. So from there, this blood goes to this part. There is oxygenator. So here oxygen or gas exchange takes place, and then from here onwards, this is returned to the patient. Let's assume we are talking about patient is on VV ECMO. This is returning to internal jugular vein in venous system only. So in simple, this is the ECMO circuit. So if we want to integrate ECMO and AKI is a very common entity. Most of the patients on ECMO, eventually they require renal replacement therapy. The best modality is CRRT. So how we are going to connect this machine with this? How many options we do have to do a renal replacement therapy on a patient who is on ECMO? First is insert a new catheter, do ECMO. तुम्हारी machine तुम देखो, मेरी machine मैं देखता हूँ. So no interference with either of the flow. So the best possibility is that, but it has its own limitations. One is the patient who is on ECMO, that patient is on continuous anticoagulation. So risk of bleeding. Already we have 2 venous access sites. So we might need another access site to fulfill the flow. So limitation of access sites will be there. and we are creating another site for infection. So these are the limitations if we want to take another access for CRRT. But with this approach, everything works well. There is no alarm on either of the machines. Second option is inline hemofilter. There is something called as inline hemofilter. I have used it once or twice. We just use it in the circuit. I'll let you know on which points. The limitation with inline hemofilter is it can be used for ultrafilter removal only. We cannot manipulate more things beyond this. So if we want to do scuff, we are limited with that only. Third option is integrating CRRT circuit with ECMO. So now how we are going to connect this CRRT circuit with ECMO, that is a challenge. So now we have 3 points जहाँ पे हम ECMO circuit पे CRRT को connect कर सकते हैं. CRRT we do have 2 ports only. Connect नहीं होगा. You need access and return. 2 connection. यहाँ पर first part is from access point to pump. I would call it as pre-pump. Then second part is pump to oxygenator. This is pre-oxygenator or post-pump segment. Third part is oxygenator to return. That is post-oxygenator segment. These 3 segments we are having. All the connections we have to understand by this only. Only golden rule is we can have multiple configuration. Only golden rule is we cannot take access from here, pre-pump, because it is creating a negative pressure. So with this negative pressure, there is very high chances of air embolization. And with that, pump will stop. So I'll just tell you one more thing. This pump generates a negative pressure of around 50 to 100 millimeters of mercury. Beyond this, everything is a positive pressure. That too very high positive pressure, 200 to 300 mmHg of range. And any return, if you want to give return from machine, we cannot post it in post-oxygenator phase. What will happen is any clot that will go unchecked to the patient. This oxygenator helps in trapping bubbles as well as clots. So anything we are returning beyond oxygenator has risk of embolism or air embolization. So now we are having 2 connections, access point. ये connect नहीं होंगे actually. Okay, ठीक है. So what are probabilities, कहाँ क्या connect हो सकता है? Combinations. So most common combination we do is we take access point from post pump. Here is access and return it to pre pump. That works best way. The only problem we do get is there is very high access pressure, high arterial pressure that usually overcomes, and the major problem is there is a negative pressure here where the return of machine is there. So the venous port alarms. So this is but still this is the best combination we can have. Second is we can have access port post oxygenator and return it pre-pump. Again similar problem. There will be high positive pressure. This will be negative pressure. Venous side there will be low pressure alarm. You just have to adjust the alarm settings. Third combination could be access post oxygenator and return post pump. So what problem you are going to have is positive pressure. You are returning at a high positive pressure side. Your venous alarm will be very high. So many times that with that alarm machine stops. So most of the times I prefer connecting it pre-oxygenator post pump as a access site and return it to pre-pump. That is the best possible configuration. So I'll just open to discussion. ECMO of course. ECMO cost. With this ECMO MACE machine circuit with the machine charge and insertion charges that usually cost day 1 3.5 lakhs. And subsequently depending upon hospital to hospital around 50 to 75,000 a day.
important, means what is most costly part of the system?
Circuit, oxygenator and circuit. So that circuit itself cost around 2.3 lakhs MRP, MACE. Other machines, they are slightly cheaper, but eventually if you see the performance, that costs similar. Over a period, how many days it lasts? MACE circuit lasts for longer. So if we are talking about a chronic patient who might require ECMO for 2 or 3 weeks, so MACE circuit I prefer.
And the cost of oxygenator?
MACE don't make separate oxygenator. Other companies make separate oxygenator. That oxygenator costs cheaply 50 to 80K. So at times we do need to change circuit itself completely in MACE as well. When there is a risk of infection or we are assuming cannulas are infected, so we do have to change not only oxygenator, the entire circuit we have to change.
Otherwise, attestation for 72 hours, oxygenator and circuit.
No. This circuit lasts for long. This complete circuit is entirely heparin coated. That life of oxygenator is at least 2 to 3 weeks. So if you maintain very good anticoagulation through and through, it usually works well for 21 days. By that time, we are very much clear whether this patient is going to land, whether we have to withdraw the support or send patient for lung transplant.
Next we have fluids and there covered. यही कर लेता. You can do it.
Yeah, one more technology we want to introduce. So for these centers where like you seen CRRT is much complicated therapy, or you don't have a user or technician expert who can run the machine. So we have a solution called HoloLens. Just a second. So this is basically a AI based tool. Using that, like after wearing this tool like this, via this you can have a in this there is a virtual picture. It will show starting from step 1, 2, 3, 4, 5 how we assemble the circuit and everything in this. This is first phase. In next phase, let's say you have assembled the circuit well, but you after let's say 7 hours or 8 hours you are getting some alarms and you are not getting through what is it for and what is the remedy of that. So in this there is a after you wear this, you can scan that alarm and you can have a troubleshooting of that, like what are the possible reasons and what are the possible remedies. Using that you can have. If not, still you are not able to get it, so using that device you can call to subject matter expert, which is me or Pratapji in that case. From there, via this, whatever you are seeing, he can able to see in this laptop or phone. He can guide you via Teams call. He can guide you, not only guide you, he can sketch, like he can drawing the things like this is the problem and you can design it. So this is the HoloLens. Via this you can communicate. So this is one more tool which can eventually help you. Yeah, like this is still under development. We have just programmed it for Sika or CRRT machine, but in near future we are coming with ECMO with CRRT integration and other than that, what are the alarms we used to face once we are integrating Sika therapy or CRRT with ECMO, it will come with. So this probably it can be very useful for in that way. So as if now, we very recently we have taken the company name Xenios globally. Xenios is the again leading company for in terms of ECMO, not in India. In India, getting your Mackay is one who is leading. So, like in near future, probably you will see Fresenius will sell Xenios console or ECMO machine, and that time we will have a integration of Xenios console followed by whatever interface or alarm is coming. Not Mackay, but for Xenios, definitely it will come.
So the topic which was given to me is the filters which are used for sepsis, and the most of which is already discussed. So basically these filters, they work with the principle of adsorption, convection, or combination of both, that is convection and adsorption. So adsorption based filters, we have already listened: Toramixin filter, Cytosorb, Alteco LPS filter. Then during COVID times, from China, Jafron 330 series, BioSky again from China. And there are certain filters which are which are being investigated, and they are being worked out, like which bind to the pathogens. So these are all the filters, they work on the principle of adsorption. And convection based therapies for sepsis, we have listened since morning, that is hemofiltration. High volume hemofiltration is often used for cytokine removal with high flux membranes. PECs, then using medium cutoff and high cutoff membranes. We have a discussion about Theranova and the IMIC2 filter by Fresenius, which is coming soon in India, which is again based on convection. It is a polysulfone based membrane. And other therapies which work on the principle of convection and adsorption, that is coupled plasma filtration absorption, Oxyris, and Hemophil, which is a polymethyl methacrylate membrane. So we have heard and mostly about these filters since morning. So I'll go a little bit in the technical details. So as far as the Toramixin filter is concerned, it is a polystyrene based filter column which has coating with polymyxin B. So since it is an adsorbent based filter, there is a chance of saturation of membranes, and the recommendation is to use for 2 hours a day, 24 hours apart for 2 times. There were initial studies which had shown much of benefit with Toramixin filter, but subsequently, these were the studies in 2015 to 18, and subsequently the recent trials, they have not shown to be of benefit for the harder endpoints of improving survival. And the Surviving Sepsis Guidelines 21, they do not recommend the use of Toramixin filters for benefit in sepsis. Then most of us have used Cytosorb many times, and this is a unique filter which is extensively studied. There is much data available also, and it has multifunctional use, like it can adsorb cytokines, myoglobin, metabolites like bilirubin, bile acids. It can be used for drug removal like ticagrelor and rivaroxaban during emergency cardiac surgeries, and toxins, that is gram-positive toxins. So basically it is an adsorbent with divinylbenzene as the polymer, and Cytosorb has a very high surface area of around 45,000 meters square, and therefore the saturation, it happens late. It can be used at a stretch up to 24 hours, and it is not recommended to use beyond that. If needed, we can use a next filter, another Cytosorb filter, and it can be used for 7 days. It has been used for 7 days in the various parts of world. Then we have these filters from China which have gained more popularity during COVID, that is Jafron series filter, HA330, that is according to the surface area, and the other is a Biosun filters, MG filters, which are available. They are made up of neutral macroporous resins, and since they are based on the property of adsorption, they can again be saturated, and they can be used for maximum 2 to 6 hours, 24 hours apart for 2 days. Then the Oxyris, which has been used more during COVID times, and we know that it works on the principle of convection and adsorption both. This filter is different because it is a tri-layered filter. The base of this filter is made up of AN69, which is coated with polyethylenamine, and there is an heparin grafting on it. So basically this negative charge adsorbs endotoxins, and this works as a filter as well. Although it works with the principle of convection as well as adsorption, still Oxiris is used mostly in series with CRRT filters for CRRT, and it can work for 72 hours at a go. Then we have lipopolysaccharide adsorber, that is Altec2 filter, which adsorbs endotoxin. It is an endotoxin filter. Again, they have problems with saturation, and mostly it is recommended, like others, to use for 2 to 6 hours, 24 hours apart for 2 days, two times. And the EMIC2 filter by Fresenius, which is soon coming to India, which is a filter which removes cytokines and myoglobulin with a cutoff value of size of 40 kilodalton, and it can be used up to 72 hours. So most of it is covered. The only thing which a little bit work on toramixin filter, the approximate cost is around 50,000 plus the dialyzer charges. For cytosorb, it is around 98,000 plus dialysis charges. Jaffron series filter, larger surface area for adults, they cost around 64,000. The other one from China, it costs around 69,000. Oxiris 70,000, and to this is the CRRT cost added. And the hemophil, which was discussed in morning, this is a filter which can be used, and if it can actually change the way which we look sepsis, because this filter as of now costs around 30,000 to 35,000 plus the dialysis charges, and it is a filter which can give us a convection as well as which can be used for dialysis as well as removing the cytokines. So anything more is, sir, 97,000 MRP. Directly from the company we can get it at 70, but in corporates it is very difficult. And sir has mentioned about Theranova, that is for rhabdomyolysis and all. So in some of the cases, differential use of filters, low cost filters, can also improve the outcome.
So, I mean, is there any specific time period during which you should be using it in the initial part? For example, once the AKI is set in, so after that, is it helpful?
Like we get a patient with documented diagnosed rhabdomyolysis, but who's not requiring dialysis. Okay, so he doesn't require a dialysis. So we have a choice to choose between cytosorb or Theranova. Okay, but somebody who requires a dialysis, Theranova scores over cytosorb because it provides dialysis also. It's a membrane, it's a slide membrane only. So we can do that. Second is cost. Theranova is just 5,000 rupees. Cytosorb is more than 85,000 rupees. So, and the timing sooner is the better. Before somebody goes into dialysis requiring state, better take out the molecule. Once they go into dialysis state, we have to biopsy them, look at the histology and then prognosticate. But better to offer it prior to initiation of dialysis. Like that's what we learned. We just saw only 2 cases, more than that.
I just have one question to both of you. When it comes to sepsis, there's a discussion on the markers and all, but then they don't reflect which part of sepsis we are as such. So using those markers, does it really make sense? Or phenotyping sepsis is an important topic.
Yes.
And initiating it at the appropriate time would make more sense rather than doing IL-6 or something which doesn't make any sense. So how do we go about in real,
we have 3 trials. One was UFAS. Second was Euphrates 1, third was Euphrates 2, and the last one was Abdominix. All those trials worked on one concept of vasopressor dependency index, VDI. And they showed benefit for vasopressor free period rather than short-term survival benefits. So people extrapolated it that they don't work in sepsis. But they showed clear benefit for drop in vasopressor. So this was polymyxin. And UFAS did the same what Dr. Deshpande was telling, they measured the endotoxin levels. None of them measured the immunosuppression biomarkers like IL-10 or soluble TNF-alpha receptor. Nobody has measured. But nowadays they are doing a ratio of IL-6 to IL-10, ratio of IL-1 to IL-10, and trying to figure out on what stage of sepsis the patient belongs. Either it is cytokine storm or was immunoparalysis, and then offer the filter.
So yeah, I got the point, but depending upon the phase, which therapy should we offer if we have the facility to do that?
Dr. Ronco says both.
No, if we have the facility to check some of the markers and characterize at which part of sepsis the patient is.
Better
Like
to do that.
if the patient is in an immunoparalytic stage, would the filter or the type of therapy change compared to the initial peak concentration phases?
Plasmapheresis scores over cytosol.
At all the phases?
No, immunoparalysis.
Immunoparalysis.
They wanted to do everything. So these polysaccharide binding filters like toramycin filter and LPS atlecto filters, what do? They bind with the endotoxin. That is the first step of stimulating immune response. So what the cytokine storm will be less, that is the principle. But as you said, the question is how we are able to clinically judge in which phase the patient is. So it's a very difficult kind of a situation. But the softer endpoints, as sir mentioned, like ventilator-free days, hemodynamic stability, lung injury didn't worsen, ICU-free days, or shifting out of the ICU, they were definitely better with this. So these softer endpoints, they have never been reciprocated into the harder endpoints of improved mortality. So the endpoint of using these filters, it should not be the mortality, because mortality depends upon many factors in sepsis. So the only thing, three things like the surviving sepsis guidelines has given, like initial resuscitation, source control and antibiotic therapy. These are proven beyond doubt to improve mortality in sepsis. So these filters, if we use early on in sepsis, we will get time to deliver the patient appropriate resuscitation, appropriate antibiotics and source control. So that is the whole basis of getting some time and getting the patient give the best of the proven benefits of the treatment. So Oxeris is being used with CRRT. Even LPS and Cytosorb are also being used in series. So all permutations and combinations have been tried, and there is data from India where 3 filters of Cytosorb are used consecutively in a patient. That is for 72 hours of treatment. And outside India, it has been used for 7 days also. The sepsis is very heterogeneous population. So we cannot compare unless and until we design studies to get the patient more homogeneous ones and then use filters and then decide. So unless and until we use it, we will never be able to actually say. The limiting factor is cost. That's it.
So for the routine where we don't have many of these markers and all, like how do we go ahead? We have a lot of septic patients who come up in the ICU. So what would be your takes on when to use these filters without the commonly available markers that we have discussed?
So what we tried to do, we tried to sub-phenotype these patients across an axis which is called as injury immunity axis. On x-axis is injury, on y-axis is immunity. So if you look at cytokine storm, the immunity is high, injury is high. Okay. as you change the quadrants, you find the multiple combinations of these. Somewhere the immunity is low but injury is high, which is immune paralysis, dissemination of infection. Some injury is not there but immunity is there. That means it's a protective immunity. Immunity is protecting actually. And places where there is no immunity and no injury, which is we call it tolerance. They don't have receptors. It is tolerant. So this was subphenotyped, attempted by people using 3 parameters. One was cell types. So they categorized it into CD17, CD4, CD8, and substances like IL-1, IL-4, IL-10, TNF-alpha, and endotoxin. So they took some data from the UFAS also, but that is not still working. So subphenotyping of sepsis has started after the definition of sepsis has changed. So now we are able to acknowledge that sepsis is not a disease of the organism dependent, it is the host dependent. It is the host response mounted to the invading organism or antigen that determines the sepsis. So we need to sub-classify them. But as people say, it is a peak concentration hypothesis. We don't want peak of any substances. We don't want peak of pro-inflammatory. We don't want a peak of anti-inflammatory. So it has to be applied. So they should be removed in both the peaks. But the adsorbents work better when there is a pro-inflammatory state, and the plasmapheresis works better when the anti-inflammatories are peak. So if you are offering delayed extracorporeal therapy for sepsis, it is plasma exchange. If you are doing it early, it is something like cytosorb or PMMA filters, hemophil filters, or HA230 can be used, HA330 can be used. So these are all early. But this all very, I know, very hypothetical. I mean, there are no studies. That's what I was discussing with Dr. Deshpande. The study designs are at fault. We are not like, we are defining everything based on hard outcomes. We are not talking about the softer outcomes like ICU, ventilator-free days, days with lessening of VDI, all this we are not talking. So I think Dr. Deshpande's study will be interesting to see how it turns out, because they have a lot of, there's a high volume in it. So let us see. But his study is still with the ethics committee, it's not yet coming out. So subphenotyping is what is required. I mean, point well taken.
How about using these extended dialysis therapies? Like we have the 5008 machines which can run for around, they can run around for 24 hours. The 5008 machines. So is it like, to cut down the cost, can we run these medium to high cutoff with high flux, and do they equate with this? Is it possible, or so?
Monitoring the patient is also important, because we should be stopping therapy when it is not showing more benefit. Patient is better, we should be stopping, otherwise we are doing more harm.
So, not related to, I mean, I had some experience of ALF patients, ALF and ACLF, and plasmapheresis was done for them. And they did not have renal failure actually, but the therapy was given by me. So I was wondering, I mean, the recommendation is I think 3 sessions consecutively. Mailed off, okay. And what happened is, on second day itself, there was improvement in INR, platelets started improving, LFT improved. So my question is whether the third session is really then required.
No, if you are getting your goals, not required.
It's not required. We can
It is
stop and
it
watch.
is goal directed.
Yeah.
You get your goals, and the goals are sustainable.
Okay.
They should sustain. Like today you saw INR is good, everything is good, you're stopping the therapy, but you have to keep monitoring. You can't stop monitoring them.
Right. So we can hold for maybe 24, 48 hours
Yes,
and
yes,
see.
48 hours
Right?
is okay.
Yeah.
But start plasma exchange, do it, 2 sessions, patient is okay, stop, wait, monitor. Again you can do a rescue plasma exchange, but that has to be with the monitoring.
Right.
That is with the monitoring. That is true. No blanket, you have to do 3 only, you have to do
Yeah.
5, nothing like that. I don't think so.
And how frequently are you using these cytosorb and other therapies for?
Not fan of cytosorb. I would prefer.
Like all the nephrologists, most of us. Cytosorb.
I'm not a fan of cytosorb. Doctor, there is a very good data from Dr. Lobo's unit. Dr. Valentin Lobo is at KEM Pune. He has very good data during CRRT. He did lot of PMMA, hemophil filters. So his data is very impressive. But he has no control population. So he did not control, like he did not compare the filter with some other filter. That is just a descriptive data. So unless you compare it with somebody or something, it won't be statistically significant. But he has good data.
That's why in the initial phase, what I was talking about.
Initial.
So I think we are the last soldiers. So, take care. Of course.